Hi. The two energies of this webinar, Dr. Malay and Dr. Mohan Rajan.
Really?
Yeah, Dr. Virendra will join and Manisha will join. They haven't joined.
What about the atomic energy?
Good evening, Dr. Mohan sir.
That is there in the host.
The atomic energy is Chitra.
Hey, let's all say happy birthday to Mohan, his daughter's birthday today.
Not me.
So, happy birthday.
Mon, we are waiting for the party.
Which party?
Your daughter's birthday.
Yeah.
Yeah.
After
Now you can
Dubai.
deliver by Zomato.
I think, Mr. Sunil, should we start?
Yes.
Mr. Sunil?
Ma'am, he said we are live.
Hi to everybody. Malay,
Very good evening to one and all of you. We look forward to meeting for a very nice ARC webinar. And this time, it's not on a Sunday afternoon. It's on a Friday evening for you all to make a difference, to make ARC even more interesting and capturing all your attention this Friday. I do hope we get great numbers to count on at the end of it. We are truly, truly lucky to have with us as on expert panel, Dr. Malay Chaturvedi, who is who heads the Akshi Eye Care Center, Kanpur. Not just that, he's a hero of the Uttar Pradesh Ophthalmic Society based at Kanpur. And I'm looking forward to a lot of inputs from him in the course of this webinar. We have with us who beats the best in all his OPLs and in anything which he does with his own style and flair, Dr. Mohan Rajan, who is the chairman and medical director of Rajan Eye Care Center, Chennai. And we can be sure that a lot of positive energies are going to come through and he's going to take us on to a lot more learning. Joining us soon is going to be Dr. Virendra Agarwal. And he's
I'm already here.
Oh, then we need to see you, Doctor. Dr. Virendra Agarwal, who heads the Dr. Virendra
Network there is a poor network, so I am keeping my video off.
Okay. Who heads the Dr. Virendra Laser Phaco Center at Jaipur, and immensely versatile and a very prolific surgeon, and will give us pearls of wisdom, which should add strength to this webinar. We have with us a pretty woman and, of course, a very knowledgeable one at that, who's a professor at the Postgraduate Institute of Medical Sciences, Rohtak, who also is the chairman scientific committee of the Haryana State Ophthalmic Society. And we look forward to a lot of her contribution and steering the way of this webinar to better directions. Moderating with me and joining very soon would be Dr. Harshul Tak, who again needs no introduction. He is the member ARC Central Zone. And more importantly, he's also that magnet who draws people to life beyond ophthalmology. He's the chairman scientific committee of the Rajasthan State Ophthalmic Society and a phenomenal surgeon at that. We shall now go on to seeing a clip of the entire video before we start on our speakers. We owe a lot to the entire videos, solid support in sponsoring all our ARC programs. Thank you very much. So we
Thank
shall now go on to our first speaker, Dr. Subhash Prasad, who's the director and the founder member and chief consultant of Divya Drishti Eye Care Center, Patna. Again, a very prolific surgeon and quite a very popular figure of Bihar state based at Patna. And he is going to take us through a very learning video. On to you, Dr. Subhash.
Thank you, ma'am. Good evening, everyone. Am I audible, ma'am? And my video, yeah.
Yes, yes.
So I would be presenting a small video on the reverse optic capture of a toric IOL. First of all, I am thankful to you for giving me this opportunity, and I have no financial interest on any of my video presentation. We all know that toric lens has actually changed, revolutionized the cataract surgery as far as astigmatism is concerned. So I got a patient of 65 years male who had pseudophakia in other eye, in one eye, with toric IOL implanted, wanted surgery in the other eye. His toric calculation sheet shows that the incision is at 183 degree and at 180 degree, and the location of the IOL is 3 degree as per the calculation sheet. And after marking the axis, I went ahead with the phaco. There is nothing much to describe here because the cataract surgery progressed in a very predictable manner. Using the Centurion machine, I did the nucleotomy with direct chop, and after accomplishing the nucleotomy, I did a good irrigation aspiration. And the problem started at the time of implantation, which I am going to show, and how I managed that. That is the highlight of this video. So I loaded the toric Alcon toric lens in D cartridge, which is supposed to go through 2.2 millimeter incision. There was no problem in loading. While injecting, I had little resistance, and all of a sudden the lens ejected out like a bullet and pierced the posterior capsule. And this lens was about to fall, and the axis of and the rupture area was at the axis of the placement of the IOL. So immediately I pulled the IOL into the bag. Then at this point of time, since the axis of the placement was lying in the area of the posterior capsule rupture, so I had to think about whether I should go ahead with this implantation or explant this lens and implant 3-piece multi-piece IOL in the sulcus with anterior optic capture. But that would have resulted in significant amount of astigmatism, or place the same lens in the sulcus with optic capture. But this is not to produce a lot of complications. So I went ahead with reverse optic capture, which is actually placing the haptic in the bag and putting the optic in the above the anterior capsular margin and capturing it. That is called reverse optic capture. So using two instruments, this iris hooks and the iris spatula, I just gently slided the optic part of the lens out of the bag and tried to bring it over the rim of the anterior capsule, and keeping in mind that I don't disturb the anterior chamber too much, and gently and gradually the lens was slided out of the bag. The optic of the lens was slided out of the bag, keeping the haptic in the bag, and trying to keep the axis of this toric lens in the area of desired axis of placement. And it required a little bit of slight readjustment at I would say about 5 minutes time. And at this point of time, I was pretty sure that there was no vitreous in the anterior chamber, but I would request everyone to put the triamcinolone at this juncture if you have any doubt of having vitreous in the anterior chamber. And having placed the lens, I did the irrigation aspiration of the visco so that nothing is left. But as such, it was not possible to completely remove. But even then, the patient's intraocular pressure was not much higher, and it required just 2 days of the astazolamide tablet. And you can see here that the axis of the placement is almost coinciding with the axis of the desired area. And the post-op, the patient did very well. This is the 2 weeks picture, and you can see it is in the horizontal meridian and just had small residual error. So this maneuver, this timely action of mine did not only prevent the falling of the lens in the vitreous, but actually ensured that the IOL optic is embraced very well in the strong and safe end of the anterior capsular rays, making everyone happy. So thank you very much.
That was a wonderful presentation and very crisply delivered. Cheers to you, Dr. Subhash. Now we shall go on to the discussion. Now I would ask Dr. Malay this question.
Yes,
now, if the axis of implantation had been in the opposite axis, And then in that condition, would you have placed the IOL in the bag and aligned it with that kind of small PCR? After all, the PCR was peripheral. Because
I think the surgery which Dr. Prashad has done, Dr. Prashad is an accomplished surgeon.
Yeah.
Is such an experienced person who could do a reverse capture with a PC rent. It was very difficult. Had it been in an opposite direction.
Sharing the video.
Say,
Video is there.
Yeah. So
Video is there.
Suppose if it would have been at 90 degree, if the lens would have at 90 degree,
yeah,
rotating would have been very traumatic. And if the astigmatism is not very high, I would like to take this lens out and put a maybe sulcus based lens and be with a bit of astigmatism. But even if the astigmatism is too high, then again you see the risk is both ways. If you are not aligning it properly, then actually you are increasing the astigmatism rather than decreasing it. So
agree.
That you have to be very careful.
No, but if the axis of alignment had been in opposite and a peripheral PCR and there's no vitreous presenting, it's already, the IOL is already in the capsular bag. We could have gently nudged it and placed it.
Yes.
Dr. Mohan, what are your thoughts?
I think it's a beautiful video, Subhash, beautifully managed.
Yes.
The only message I want to give everybody, because I've got probably one of the largest complications with IOL implantation. You must have seen my videos on IOL antics and acrobatics. But whenever there is a resistance while implantation of the lens, okay, please don't use that lens. Come out of the eye and maybe re-examine the cartridge or change the cartridge or do something different. Don't try to push this lens inside. If there is a resistance, you can have a crack on the lens, either on the optic. We have seen that in several of my videos, or the haptic, or this can happen also. A sudden, release of the lens and rupturing the PC. But once it is good, because I don't believe in this wound assisted this thing if it's anymore. But wound assisted, you have to be a little more careful. Always make sure that the force in which you inject the lens is a little controlled. So I think this is a very good video, but the reverse optic capture is not an easy joke. He did it so easily. He made it so easy. And the reverse optic capture, because these are all optic lenses, and I'm sorry, single piece lenses, wherein there is no angulation between the haptic and the optic, and it's very difficult to do the reverse optic capture.
Actually,
but he did so well. Yeah.
Actually, you also need a very ideal size rexis to do a reverse optic capture.
Yes, fortunately, he had a
5.5 to be exact, or a little smaller too. And because if it's a little larger, then it won't even stay the way it stayed on. It is just a freak chance that he got the right size rexis, because no angulation is a definite challenge. Now, supposing now you have placed it, would you add any extra medication to this, Dr. Manisha? You have to unmute yourself.
Oh, sorry. First of all, thank you very much, ma'am. This was a wonderful video. Only a master could have done this. I was wondering, even when I was watching, this reverse optic capture was very difficult. And like you said, I was wondering what was the size of the rexis and what was the size of the optic. So basically, even the post-operative, I would not like to call this patient for a long follow-up. I think a frequent follow-up is more important to check in the post-operative time. And I think that the routine medication, why? Because you said no vitreous had presented itself. So maybe we would not expect more reaction in this patient.
But the haptic is in the bag. Haptic is not in the sulcus, so it's not rubbing on the iris.
Yes, but the optic is rubbing on
there. Yes. Optic is there, but if it is a small size pupil, do you think there will be a rubbing of the optic on the iris?
There is a possibility.
Yes, but we are presuming that these materials are inert generally. So we are hoping that it did not. But like I said, I would like a frequent follow-up on these patients rather than calling after a week or so, maybe daily for a few days to see that they don't have increased reaction.
Dr. Malay, supposing the PCR had been a little larger, what would you do? Like, Dr. Subhash was caught in a quandary because the patient had a toric in one eye and the other eye toric he felt compelled to put, and he managed very well. But if you had a little larger PCR, would you still go ahead and place an IOL in the bag?
So I think if the PCR is too big, then
Not too big, a little bigger.
it's
Not
again,
too big, you can't do.
it depends on whether you can actually manage the lens in the bag or not.
Mm.
Now, suppose if the PCR is too big, then we will have to look into a transspiral fixation rather than doing anything which is very heroic in the
No,
bag.
rexis is intact, no, Malay.
The rexis is
The rexis
intact,
is
no.
why we can put a multi-piece lens in the sulcus and capture it.
Capture it.
Yeah, regular optic capture it can do.
Yeah.
Yeah, multi-piece lens and do an anti-vitrectomy. Of course, he mentioned that, Subhash mentioned that about the use of tricot, end of making sure that, because sometimes you can see the vitreous can be there in the anterior chamber. So make sure that you put tricot and identify the vitreous if it's there, and then put the myocol to make sure the pupil is round.
Yes. Very good. We shall now go on. Excellent, Dr. Subhash. Stay on for your valuable contributions over the other webinar, other videos which are going to come through. We shall now go on to our next speaker, Dr. Tirmalesh. Dr. Balla will join in a while. And he's a senior consultant ophthalmologist and vitreoretina surgeon from Narayan Netralaya, Bangalore. And let's look forward to see another. And let's see what he has to show us.
Thank you, Dr. Chitra ma'am. I would like to thank the ARC and Dr. Chitra for this kind opportunity to show a cataract surgery despite being a VR surgeon. So my case is straightforward, fairly simple. I hope one can see the video. So this was a 57-year-old female who had undergone a VR surgery for a diabetic TRD. As you can see, when I started, the pupil was small, and I tried to put in a small air bubble and it escaped out. So one learning point is that in a post-vitrectomized eye with silicone oil, there is a lot of upthrust that is going to happen. So putting a pinky would be a good idea. Because it was a non-dilating pupil and a little floppy iris, I had planned that I'll put a Malagian ring. You can see that I had made a 2.8 incision and I put the Malagian ring in, which did not directly go beneath the iris. So I used a second instrument to manipulate and insert it. And once I had established a good 5.5 to 6 millimeter exposure of the capsule, I used a cystitome to make a capsular rexis, which was continuous and curvilinear. So I did check by putting some more visco to see it was continuous, and then I did a good hydro to rotate it. So other important thing that one would notice if you are operating cataracts in patients who had undergone VR is that the nucleus, although was giving a good red glow, but it was a pretty hard nucleus. So be a little prepared for harder nuclei, because what appears to have a good glow would not be correspondingly that soft. So you can see that this particular nucleus is pretty hard. Another important thing is in diabetic patients, the central nucleus will be a little more harder than a little periphery. So I employed a slightly peripheral chop in this. So I did a good vertical chop, but a little in the periphery. You can see that the chopping in this particular case would probably yield as something like a flower petal kind of an appearance. So one can also do a little debulking like I did, and then initiate the chop so that it tends to be full thickness. So this quadrant, you can see that the central core is separating from the peripheral area, but the chopping, one can initiate another crack and make sure that it kind of becomes more and more full thickness. It's also to note that once we are operating in post VR eyes, the zonules might be a little weak, so one should not ensure that the pressure on the capsular bag is too much. So once we ensure these things, I think the surgery becomes straightforward and fairly simple. And why one would probably choose a Malagian ring is because it avoids those multiple incisions when you are trying to put in iris hooks, and there can be iris prolapse and repeated iris coming out from there. In a Malagian ring, that kind of gets eliminated, and these floppy irises can be managed well when we tend to put a Malagian ring. One can also use probably the other rings that are there, but this is fairly commonly available with us. So once the nucleus was removed fully, there is hardly any cortex left. you can see that, the upthrust is slightly there when we remove the instrument, and, some amount of posterior capsular opacification is usually present. So what I did in this particular case was, after finishing the cataract surgery, I removed the Malaysian ring, implanted a lens, and when we did the SOR, I also, at the same instance, I also did a small capsular opening.
Okay. We are not able to hear you.
Oh.
Okay.
Now, ma'am?
Yeah, but the last bit we didn't hear. That's okay. You showed us the main chunk of it, and that was again a wonderful video, and a lot of discussions is possible. Dr. Mohan, want to know something very, very basic, but something which all should know. You're doing biometry. What are the things which you would give attention to in these silicone oil filled eyes? Like
no, if you have an IOL master 700, then you can go in for that particular formula. The silicone oil filled eyes automatically it'll So please understand that the silicone oil filled eyes, they become more myopic. So the post-operative, they have more hyperopia in the so you have to be because there is a convex oil inside the eye. So you can go in for a fellow eye if you have got access to the fellow eye implantation, and they can do that as well. So normally what we do is we also when we do the cataract surgery, we remove the oil as well. So yeah.
No, but if it is immersion, then we need to remember that we have to change the velocity for
velocity of the yes, absolutely.
So now, does it actually make sense that if you're going to do a pars plana vitrectomy surgery, that keeping in mind that these patients are likely to get cataract, does it make sense to do a biometry beforehand? Your thoughts, expert panel?
What I would say, what we are doing now is mainly a combined surgery. Yes. Anybody above the age of 50, we do a combined phaco and vitrectomy together. And right at the beginning, even if because most of them, they'll have some lens changes or nuclear sclerosis grade 1. And when you have a TRD or something like that, then we combine the phaco and vitrectomy together. It makes life easy. And one surgery for the patient, if the oil is there, then after a couple of 3 or 4 months, we just go in and remove the oil as well. So we do a combined surgery mostly, but we do a routinely IOL master and lens star for all these patients, even if they undergo vitrectomy on a routine basis. Yes. So I think makes a lot of sense in that as well.
Yeah. Now, Dr. Tilmilesh, what did you do to open the posterior capsule? They used a vitrector?
Used a vitrector, yes.
Used a vitrector and did it. Now, Dr. Malay, if silicone oil is seen in AC when you're doing the cataract surgery, so what it would it make you wonder about? Like, would you take any extra caution or anything? I mean, this does happen. My thoughts were silicone oil coming in AC because these eyes who have vitrectomized eyes, they could come with some amount of zonular weakness. So it could also, there could be an inadvertent lens touch and there could be a PC opening too. But if the PC appears to be intact, but the nuclear fragments are very much in the bag, then would you immediately think of putting in a CTR at that point of time? I would want all of you to tell me. Any of you could tell.
I would not plan a CTR, ma'am, because many a times there might be a localized area from where this oil might be coming. So you can test that by pushing a little oil, it usually goes back. And until and unless there is no obvious fluttering of the bag or you have known that there is a zonular weakness, I don't think CTR, I usually do not put, ma'am.
Okay.
Yeah, not routine. See, what happens is oil in the anterior chamber is not uncommon in any patient who's undergone vitrectomy with oil, because the zonules are going to be weak. Through the zonules, it will come. Only thing is, the small amounts of oil, you can try to aspirate it and go ahead with the phaco.
I'm not next, no?
Yeah. But if you can see the floppiness of the posterior capsule. And once you remove the nucleus, if the floppiness of the posterior capsule, that is probably one of the indications that probably CTR may work. better in these conditions. The floppiness of the posterior capsule is something which is very, very important, especially when you remove the cortex. In this case, there's not much cortex, more of nucleus and not much cortex. But when you remove the cortex, then every time you remove the cortex, you can see the entire bag. There can be wrinkles on the posterior capsule, and very difficult to remove the cortex as well. And that is an indication for probably CTA, because the zonular weakness can be a little universal or 360-degree in these patients.
Yeah.
Especially in myopes, the brag kind of starts breathing on you. So, when you see that, consequently, that if the bag at one zone is, fluttering a little more than usual, then probably a CTR would help.
Yeah. But how many of you, with all these challenges, would actually want to go and do a vitrector and open up the PC when the bag would be floppy, when there may be a need of a CTR? Would you want to let the PC plaque remain there and place the IOL? Does that also make equal sense?
Ma'am, can we deal with the plaque later also? Because we can do a YAG later. That's what I was wondering. Is it important to open it up at the time of surgery?
Yes.
Or can we just leave it and deal with it later?
The problem with these plaques is in silicone oil is a very, very thick plaque. Yes. Very difficult to do YAGs. Yes. So either you need to cut with the cutter, or sometimes I've done posterior capsular excision also in these patients. And but you need to use a cutter because the plaques are very fibrotic and very thick. And
they're like membranes.
Very difficult to use. You need to use very high energy, just like the pediatric capsule, it is like that only. So
chances of
YAG
dislocation
laser may not be suitable.
Yeah.
Okay.
I think with cutter, ma'am, if you use lesser suction and if you can keep the cut rate at about 2,500 to 4,000 and use the suction at about 90 to 100, we can achieve a good round posterior capsular opening.
Okay, very valid points.
Chitra ma'am, regarding this silicone oil in anterior chamber, this actually, once you remove it before doing the phaco, if you even after implanting the lens, this silicone bubble in the anterior chamber keeps coming, and that actually makes some problem while doing the silicone oil remover and subsequent examination of the retina. So what I do is that once I implant the lens, I keep some visco over the area from where the bubble is coming out, so that the bubble doesn't come unless whole silicone is removed from the posterior side, and that makes visualization better.
And a lot of these eyes come to us for management of glaucoma because of the intraocular pressure, the silicone oil eyes. So what is your experience with that?
Usually, we do an early oil removal these days.
Okay.
So,
that is
if the lesion is not there, then trabecular mesh of fibrosis kind of is usually a finding which tends to set in later. So, unless you have emulsified oil with associated trabecular mesh of fibrosis, they tend to do well once you remove the oil.
Dr. Chitra, can I comment?
Give justice to other speakers too. Who wants to comment?
Dr. Virendra Agarwal.
Yes, Dr. Virendra Agarwal. Oh my God. I think we need to see you. What am I doing? I missed you. So sorry.
No, nothing. No, okay. I want to comment on this thing. The silicone oil comes usually from a very small, weak area of zonules. So my opinion, CTR is not required. CTR is usually indicated when zonules are compromised in a larger area, and that too by trauma. Means those are not normal zonules.
Yes.
In this case, the zonules are usually normal, so you don't require CTR.
Absolutely.
Another thing I want to comment upon for glaucoma is that usually the emulsified silicone remains in the angle. So at the end of the surgery, use pilocarpine, reduce the pupil size, and do lots of irrigation aspiration at the angles. So what I do, I am already fan of bimanual. So I do the bimanual irrigation movement all around 360 degree with the irrigation on. So that release some of the bubbles which are there already in the angle. And sometime you require to do the same after 2, 3, 4 days or some days later. You do the aspiration of these silicone oil bubbles from the angle will reduce the incidence of glaucoma like anything.
Yes.
Many patients who come with the glaucoma post-op, you do gonioscopy, and if you find the silicone oil is there in the angles, again do the same AC wash through the bimanual cannulas, and you will see the wonders in the glaucoma management by removing the silicone oil. Because if silicone oil is there in the angles, it will not let the glaucoma settle. So that is one thing. The another thing that whenever you start cataract surgery, if silicone bubble is disturbing you too much, then you try to let the silicone oil come out as much as can come before doing the cataract surgery. Keep your slightly irrigation on with the bimanual, and some of the silicone oil which is emulsified will come out by that in the antechamber and will get washed out. The larger bubbles will not come and interfere the surgery. So that is my few points for the silicone oil surgery.
Very valuable points. These were the exact things which I had wanted to be brought out, and I'm so glad to have your inputs. I really wish your video had been on. We shall now go on to our next speaker, Dr. Cyrus Mehta, who's again a director of the Cyrus Mehta International Eye Center, Mumbai, based at Kolaba. Absolutely dynamic, very innovative surgeon, and he's going to show us something different. And I'm sure it's going to rake up a little controversy. On to you, Dr. Samresh. Are you there? He's seeing a patient. Dr. Samresh? Oh, he's not realized it. Okay, Dr. Charuta? Dr. Samresh? He's not. Dr. Charuta, I think we will go on to you. You have to tell Dr. Samresh. Dr. Charuta is a senior consultant ophthalmologist who's a cataract, refractive, and a cornea surgeon. And she is the founder of the Oculus Regeneris Eye Care and Research Center. And as you would continue to know, she's a absolutely versatile, calm, and a very confident surgeon. On to you, Dr. Charuta.
So good evening, everyone. At the outset, I'd like to thank All India Ophthalmic Society Academic and Research Committee Chairman, Dr. Chitra ma'am, for conducting these sessions. My video is visible and I'm audible, right?
Perfect.
So this is a patient with relentless peripheral ulcerative keratitis, which was not responding to conjunctival resection and was on immunosuppression since quite some time. Now, his chief complaint was that he wanted to read the newspaper. So we just saw his outcomes a few months later. Now, I want to introduce the patient. He's a 60-year-old male. He has aggressive Moran's disease. Twice I've performed conjunctival resection and TABCL, and he's also on systemic immunosuppression for the inflammation. And in his left eye, we see that it's a really small pupil, non-dilating. And the plan that was made for him was small incision cataract surgery with iris hooks and combining it with a keratolimbil allograft. So this is the first step where I'm trying to where I'm removing the amcrolate glue, and also I'm removing the epithelium, the new epithelium that has formed below the resection. Also, you can see the visible edges of the conjunctival resection, after which it has also epithelialized later. I'm not using the cautery at any point in this because the sclera is already thin and I've already used a cautery in the first two surgeries. Now, I'm just trying to clear off the epithelium, and then I'm taking a frown incision with a 15 number blade after stabilizing the globe with a very fine tooth forceps. Now, the depth of the incision is checked again with the crescent, whether it's okay all throughout, and then the tunnel is constructed, including all the side pockets. So at all points during this maneuver, the crescent blade is perpendicular to the sclera, or rather going along the curvature of the globe. So note that the blade is actually very visible through both the sclera, which is generally not an advisable thing in small incision cataract surgery. However, we are dealing with a very thin sclera and cornea here, so the normal parameters are not exactly viable. The entry with the keratomy was made around 2 millimeters from the limbus, and that would be what is desirable. Now, at this point, I want to point out that a sharp new crescent was used, and also stabilizing forceps were at every point kept away from the tunnel flap because we didn't want to injure it in any way. And again, I reiterate, no cautery was used. Also, in the next few steps, we'll see that no vectis was used because we didn't. I didn't want to injure the tunnel in any way as to destabilize it. And although the tunnel was self-sealing, single suture was still used in order to secure the wound. Now, the rest of the surgery was conducted for as per we would for a small pupil. So we have iris hooks which are being used, plenty of viscoelastic, manually the lens was mobilized into the anterior chamber and then visco expressed with very minimal manipulation. And then actually the red glow was very well visible during the case. However, it's not being captured in this system. A 3-piece lens was placed, assuming that I'm not going to be able to see whether it's going in the sulcus or not because of the tremendous haziness in the peripheral cornea. So the self-sealing wound was checked again. At this point, then I went on to create the keratolimbal allograft lenticules, and then these were then fixed to the peripheral thin cornea. You can see 6 lenticules have been fixed with a combination of 10-0 monofilament nylon and suturing and fibrin glue. And the same fibrin glue and whatever possible conjunctiva was also used to close the tunnel, to cover the tunnel. So at the outcome, after a couple of months, the patient was able to actually read binocularly the newspaper, although his vision in this side didn't improve much beyond 624.
Challenging video and must have been a great job done is so obviously seen. What I wanted to ask was, my network is a little unstable. I would want the expert panels to support me when I get missing suddenly. I don't know what's happened. How do you did a scleral incision, which is wonderful because there's no scleritis associated with PUK in this particular case. But supposing there was scleritis too, how would you have managed this case?
Ma'am, the immunosuppression would have to be stepped up a lot, much more. And ideally, the gap between acute inflammation and any surgical intervention is 3 months.
Okay.
So in this case, we've already intervened twice, and the patient was having multiple other systemic issues, diabetic and hypertensive. So we had him in a window where we wanted to do the keratolimbal allograft, and he said, whatever you do it only once. Okay. So we decided to combine both the cataract surgery and the keratolimbal allograft. But obviously, with an active scleritis, it's not going to be possible to intervene in this case at this point.
So then, what is the time between the when you decide after activity? Just like uveitis, a 3 months or 6 months? How long?
Of quiescence, yes, ma'am. Yeah.
Quiescence, and then you do it. And what is that extra immunosuppression which you give? I'm asking her questions myself. I'm sure I would want the expert panel to take some questions too. What would be the extra immunosuppression which you would add in this particular?
In this case, the patient was already on topical steroids first, which were tapered down, oral prednisolone, which was again tapered down, and simultaneously he was started on oral methotrexate. So my preferred immunosuppressive agent is methotrexate, although cyclosporin is also quite a favored one by many immunologists. So I tend to step up the dose. So if I start with 10, then move it on to 15. And then cyclosporin 50 milligrams is also another way to go.
So you have used iris hooks. They were all scleral incisions, right?
Clear corneal, no ma'am. Just at the limbus.
Limbus.
Just at the limbus, yes.
Oh, okay. And
posterior limbus.
Posterior limbus.
Yeah.
Posterior limbus. Don't you think you could have thought of, you managed well, you could have used some endo-illuminator, transconjunctival or something, or you were able to visualize?
I was able to visualize, ma'am. The red glow was quite visible after using the hooks. but somehow it wasn't captured. The place where I operated didn't have a great capturing device. Neither did I have access to an endo illuminator then.
Yeah. That was
Ma'am,
a
can I?
Can I
yes,
make a comment,
Dr.
Chitra?
Mitra, all of you can comment. Yes,
Chitra,
Mohan.
Yes.
Can I make a comment?
Okay, yes, Mohan.
I want to ask one question first.
Yeah, no.
So, Cyrus, you have to
Before that, I want to
speaking
make one
next?
comment, Cyrus.
We called
Am I
you a lot,
speaking
Cyrus. You are speaking next. Next, you are
Yeah,
speaking.
Charutta, I want to give you 200 out of 100 for this video.
Yes.
Seriously, I'm telling you, fantastic. But
Fantastic.
only thing is, why you couldn't do a phaco in this case?
Actually, because the pinpoint pupil,
Clearly-
I couldn't assess the grade of the cataract pre-operatively. So better safe than sorry type. So I decided to do, I planned an SICS, then dilated the pupil intra. So another way to have done it would have been to create the iris ports first, iris hook ports first in the grade, but then
Yeah.
it would still have been a hit and miss, Brunism cataract I could have missed.
Yes.
Can I comment, ma'am?
Yes, yes, Dr. Manisha.
Yes. First of all, beautiful surgery for you. Daring to take on this patient is wonderful with this thinned out sclera and cornea to make the tunnel. A lot of my postgraduate students are watching, so I want to tell them to make this tunnel is extra difficult because it's already thinned out. You could have easily had a premature entry in which your iris would have troubled you throughout the surgery. The other thing is visualization is very less, and you said only 624 vision. I think in this patient, 624 vision is very good, because it is still useful vision in this patient. The other thing is that would you add an anti-glaucoma agent? Because you cannot monitor the intraocular pressure accurately in these patients, plus you give topical as well as oral steroids. So I think that you can add, at least for 6 weeks, a topical anti-glaucoma agent as well. The other thing, the suture. To apply a suture in such a thin scleral flap, I think your tunnel was good. And you could have just left it. Sometimes you need to apply a suture, but in this, you could have just left it without that suture, especially in this patient.
Yeah.
Noted.
Yeah. These are points. Yes, points for suggestion. And
Very nice.
the thought of using anti-glaucoma medication would be more if there is a lot of inflammation in the eye. I mean, you are thinking of steroid responder.
Yes, ma'am. We get a lot of them, surprisingly.
Yeah.
So,
yeah, that's a thought. So thank you very much, Charutta. Wonderful video, and stay connected with us. I'm sure we would learn
Very
a lot
nice.
from you as we move on. Yeah, a
Thank
big
you.
clap.
Thank you for allowing to present.
Yeah. So we shall now go on to our next speaker, who should have been the earlier speaker. I hope he doesn't go on to his next patient now. Dr. Cyrus Mehta, an extremely dynamic surgeon and innovator.
Hi,
who
can you all
follows
see
up-
my screen?
You don't want your introduction. Okay. At the
No,
end-
But you all can see my screen, no?
Yes, we can see
The
your
screen
screen.
share is working, no? Yeah, okay. Thank you, ma'am, for calling me. And thank you for having me. And hello, everyone. And hi, Mohan
Let
Rajan, sir.
her
How are you?
introduce you. Yeah,
Okay, now you continue with the introduction. I was just checking if the system was working.
Is incorrigible. So that may be and a very innovative surgeon. Like, he will show you things which might seem bizarre and unreasonable, but he will get away with it. His patients also get away with it. And sitting in Kolaba, I'm sure he has to be very, very conscious about how challenging his patients would be. So kudos to Cyrus for all that he's doing. On to you, Cyrus.
Thank you, ma'am. The surgeries that don't work well, I don't show the videos.
Cyrus, you're being heard by many people. Be careful.
Yeah. So this is the video I wanted to show. It's something little different. So this patient lands up, has been seeing me for 2-3 years, and he has a PC lens in the AC because whoever did the cataract surgery ruptured the posterior capsule completely. And then, he had only a PC lens. So he figured that why waste, we'll just keep it in the AC. So he developed a little bit of glaucoma, and the cornea went into total decompensation. So this was the situation. So I decided to make a scleral tunnel because I wanted to do a DSEC along with the explantation and implantation. Otherwise, I would have simply tried to remove this through a small tunnel and then put in a foldable lens and flanged it. But I put a PMMA lens because this was a large lens and it wasn't going to come out through any small opening. And anyway, the DSEC graft is not going to go in through 3 millimeters. So I had to open it and do a 6 millimeter tunnel. So let's see how it went. So that's your tunnel, removing the epithelium to have a better view. There's nothing much to remove the lens, it's already lying in the AC. So that's a nice 3-piece PC lens that was in the AC, anterior chamber maintainer, anterior vitrectomy, and then 2 millimeters behind the limbus. You put the 30 gauge needle after passing the 6-O-proline. So I much prefer to do a little conjunctival peritomy because I've had cases where the flanges got externalized earlier. So I always tuck the flange in and then close the conjunctiva. Here's the dissect. I'm not very good at it. I'm kind of still learning this procedure. So I got the 2 sutures out and I flange it by passing the suture through the upper, from the eyelet of the PMMA lens. Always remember, you pass the suture from up and create the flange from down. So you tuck the lens in and then the trailing haptic, you pass the suture like this and then flange it from down with the low heat cautery. Then put the lens in the eye. The lens is sitting nicely in position. Close the conjunctiva. Put a sheets glide. And that's the dissect. Lamellar graft that goes inside. And of course, I had to close the tunnel with sutures, otherwise the air bubble will come out. So I had to close the side port also. And this was the end of the surgery. So regularly, I come across cases where there's a PC IOL in the AC. And generally, the cornea always packs up. And that's why you have to do an endothelial keratoplasty along with this surgery. And that's why I showed this video. I'm not very good at doing a scleral tunnel. I'm sure there are better SICS surgeons who would be able to do a lovely scleral tunnel and wouldn't have to put sutures, but I'm not one of them. So that's why I thought I will show this video, and this, instead of showing the same one I show every time, I've showed this. All right.
Yes, that's nice. I was thinking I was going to see a subluxated video. I just wanted to ask you.
I have the subluxated video next, but that will be 3 minutes more.
Yeah, no.
If you want to see that, I can do that.
No,
I
want Dr. Mohan's thought on it. Dr. Mohan, how do you ensure these IOLs are centered IOLs? What are those small things which one would do to ensure they are?
Basically, see, it's a very big lens.
No,
it's a 6.5 millimeter PMMA.
Absolutely. Absolutely. It's not a very major issue centering.
Yeah.
The message I want to give, I think Cyrus has given very nicely, is that when you have a PCR, okay, just because you have only a PC IOL, don't put it in the anterior chamber. This is a mistake everybody does. When you have a PCR, it doesn't mean that you have to put a lens. You can leave the patient aphakic, and probably after a couple of weeks, you can reassess the situation. There can be a capsule there, fibrous capsule. You can put a lens in the sulcus, a multi-piece lens. So I think don't hurry up and do and mess up the whole thing. And that is what has happened. And Cyrus beautifully has shown that. So you have to explant the lens and put a flange. In the flange lens, the advantage is that just like the glued IOL, the centering, you can tuck it on one side, pull it on the other side, and the centering automatically occurs. It's not a very big issue in centering these lenses.
No, these lenses were big, but I think this should be at equidistant from the limbus on either side. And
yes.
And it should be on the same plane. You should have
0-180. You need to mark that 0-180.
Yeah. 0-180, yes. And that is a thing. Dr. Virendra Agrawal, would you want to add something, Dr. Malay?
Ma'am, I would like to say something here.
Yes, yes.
Of course, beautiful surgery, but most of these times these patients come to us. I asked one of the surgeons whom I knew was working another setup, that why did you put this IOL? They said they did not want to admit to the patient that there'd been a PCR. So one of the reasons is normally people keep a library of ACIOL also with them in the rare instance of this. So sometimes the surgeon doesn't want to admit, but the patient comes to know sooner or later. They come to us with secondary glaucoma and decompensated corneas. The other thing I wanted to know about this tunnel and these sutures, I'm so sorry, but I have to ask, what is the surgically induced astigmatism? Because that becomes a big concern for the patient post-operatively.
Yeah, so these were actually, if you saw, they were 80 vicryl sutures.
Yes.
So the sutures kind of give way anyway after 3 weeks, and most of the astigmatism disappears. And the patient was left with about 1.5 to 2 diopters of astigmatism, which is okay because his vision was so bad for so long that he didn't expect very much anyway. And he was avoiding surgery for years. 2-3 years back, this was done. He was avoiding surgery, avoiding. Finally, when he just couldn't avoid, vision was very bad, and there was constant pricking and burning in the eye. Then he decided to do the surgery. I've been chasing him for 3 years to do the surgery.
Okay.
Astigmatism is not a major concern.
Yeah, it's not a major concern.
Yeah.
Thank you. There are many on the list, so we'll have to move on. Thanks a lot, Cyrus. Do connect
you,
back.
Well done, Cyrus.
Over. Well done.
Thank you, sir.
Yeah, we shall now go on to our next speaker, Dr. Suresh Pandey, who's a founder of Subi Eye Institute and LASIK Center from Kota. Again, a brilliant surgeon, and he's going to show you a very challenging moment which he has dealt with. On to you, Dr. Suresh.
Thank you very much, Dr. Chitra ma'am. And first of all, I would like to congratulate you and entire team for organizing the beautiful AIOS ARC top pearls in the cataract surgery. And today I'm going to show 2 different cases of phacoemulsification postural disorders. Sometimes we encounter situations like this. 56-year-old gentleman who has a history of congenital thoracic kyphosis, and he is unable to lie flat on the OT table. This gentleman presented to us with the cataract in both eyes, and most of the surgeons were not very comfortable to perform surgery of this gentleman. We took him in the OT, we did the mock drill, and this surgery was done in the year 2010. So we just asked him to lie down sit on the table, and the surgeon took the standing position, and you can see here the cataracts is being done, and we used the basic 1FR Zeiss microscope, although the mounted CD microscope can be helpful in such cases, and the surgery was a little difficult and challenging because of the unusual position of the patient and this standing position of the surgeon. Here I'm doing the surgery with my left hand, and you can see the incision was made on the temporal side, and I'm using my right hand to chop the cataract. The entire surgery was uneventful, and we did the irrigation aspiration, and this was followed by the implantation of a 3-piece intraocular lens into the capsular bag. So many times we face this situation of phacoemulsification in postural disorders. Patient of kyphosis, Meniere's disease, COPD, or ankylosing spondylitis, etc. They come to us and they are unable to lie flat on the OT table. So in these cases, it's important to do the mock drill, explain about the possible complication to the patient, and to explain surgeons should take these such cases. And once the surgery is done, luckily we were lucky enough that there were no complications, and the case went very well, and the patient regained 6/6 vision in the post of unaided, and with the plus 2.5 that addition, the near vision was perfect and 6. And here I'm going to show you another case of 55-year-old female. C was a case of cardiopulmonary disease, Meniere's disease, and obesity. So we used plastic chair to perform the surgery. Here the patient is seated on the plastic chair, and her feet were extended, and she put her feet on another chair. And we used the support of the surgeon's stool, and her neck was extended, and she was looking towards the roof of the operation theater room. The surgeon once again took the standing position, and here you can see the surgery is being done. This is the cataract. And the difficult part was that you cannot use both your feet while performing surgery. So what we did, we just asked our assistant to use the foot switch of the OT table to make it up and down. We fixed the microscope and we made it in focus. And then we used the phaco emulsification machine to emulsify the cataract. And we used the 1 foot on the foot table of phaco machine. And the patient surgery went very well. We implanted the cataract multifocal lens and the patient began 6/6 and 6 vision. And it's a very difficult scenario. Sometimes we do encounter cases of phacoemulsification postural disorder. It is very important to do the mock drill and explain about the pros and cons and then take these cases. Thank you very much.
Thank you very much, Dr. Suresh. That was an amazing video which you showed. But I just wondered, especially in the first case, if you keep a lot of support in the lower back, you could make the patient lie down so that the head is in a more near normal position. You can sit and operate. Because I don't know how you could give a foot pedal to your assistant and operate. I mean, it's phenomenal first, very difficult. I don't know. I'm hats off to you for what you did.
Chitra, can I make a comment?
Yes.
I would agree with you because I've done a couple of kyphosis patients, wherein what we do is we just elevate the foot end of the patient. We stand backs and we used to elevate the foot end so that the legs, the feet will be vertically facing onto the ceiling so that automatically the head end comes down. So that makes life easy. Otherwise, it's very difficult. I've also done surgeries wherein the patient is not able to lie down. I've done in the sitting position. The only thing is you need to orient your microscope. The tiltable optics are there with all the newer microscopes, the higher end microscopes you can have. You can just tilt it like that and you can use it as well, but it's a little more difficult. But raising the leg end makes more sense actually. You can get the,
Yes, Dr. Mohan Rajan, I think that's very important point you have mentioned here. And this case we did in 2010. So that time, like we just have, it was the first case. So we were trying to figure out the best way. And this is, I think your suggestion is wonderful. And you can use the high-end microscope and you can use the table, to take its advantage so that you can manage these cases nicely.
Dr. Malay, you want to add something? Dr. Malay, we can't hear you, or my.
Hello, can you listen?
Yeah, yes.
Listen. Yeah. Hello.
Yes, we can hear you.
Yes.
Yes.
Yes. So I fully agree with Dr. Mohan Rajan. You see, we have seen these patients, and you keep if the hunchback is like this, if you rotate it like this, the leg end goes up and the head becomes horizontal. It is easier to operate when you're sitting. So surgeon's comfort is also very important. And you have to remember that suppose it's not about heroism of the surgery, but predictability. And predictability definitely goes up when the surgeon is sitting. So I think that point is very well, it has to be understood. And you don't need a high-end microscope. OPM 1FR is a fantastic microscope to operate with, and posturing, as has been mentioned by Dr. Mohan, is a very good idea we have done. We have raised the leg end and made the head horizontal. A bit of intraocular pressure related issues come, but if you're careful, then you are able to handle it. And
have you also, all of us, yeah. I think all of us also need to remember that these patients could need an anesthetic standby when you're operating. They could have some cardiopulmonary.
Because their heart
we should play it safe in the present day. Yeah.
Absolutely.
Yeah. Wonderful, Dr. Suresh, and really. Thank you. We shall now go on to our next speaker, Dr. Samresh Srivastav, a young dynamic surgeon from Raghudeep Eye Hospital, Ahmedabad, and also has his own standalone practice in Jaipur. And he showed us around his clinic, which is so amazingly nice. and he has been a winner of innumerable awards at the international level and has always great content to show and teach. On to you, Samresh.
Hi, Samresh.
Yes, unmute yourself, Samresh.
Good evening, madam.
Yeah.
Thanks a lot for the lovely introduction, madam. And it's my honor to be a part of this program. And I'm sorry once again for the delayed video that I sent. So I'm going to discuss a case. So this is quite similar to the first case that we had discussed today by Dr. Subhash Prasad. I have a patient with a toric IOL. Now these are one of those cataracts which are neither here nor there cataracts. They're not very dense. And at the same time, they're not very soft. So you're not sure whether you want to chop or you want to do a 4-quadrant. So I did a chop maneuver in this patient, but then I realized that the chop wasn't complete. So I shifted my gaze from chop parameters to a 4-quadrant parameters where I reduced my flow rate, very low flow rate, and I'm playing with right now of about 8 to 10. And I'm trying to ease out that posterior plate that was stuck in over there. Sometimes it's very difficult to visualize this, especially in these cortical cataracts. So once I saw that it was gone, the posterior plate was cracked, I decided to remove the fragments. But while I was removing my first fragment, I could see an area of clearing. And for all the surgeons out there, you know how, the kind of sinking feeling you get when you see this sort of a picture, when the posterior capsule is clearer than it should be. And it's pretty evident over here that there is something that has gone wrong in this area, which is visible over here, which is quite evidently an open posterior capsule. When a situation like this arises, I think it's our duty and responsibility to first identify the vitreous. And having identified this, I think for us, for now, for the last almost about 6-7 years, our go-to choice is to do a pars plana vitrectomy. So we have a limbal irrigation and we have a vitrectomy probe through a trocar cannula system where I'm underneath the posterior capsule, clearing up the vitreous, preventing it from prolapsing anteriorly. And I'm using the irrigation anteriorly to keep the anterior chamber stabilized. The idea for vitrectomy for me is not to do a core vitrectomy, but just to clear up the area in the posterior capsule opening so that I have now enough maneuverability in that area because my incision is temporal and I have to remove this nuclear fragment. So one of the choices I had was to make another incision and suture this, but I decided to go ahead in the same area. But because with the newer machines, particularly with torsional platforms and good followability, there is now distinct advantage of having that nucleus which is always going to stay close to the probe. So notice I've split my irrigation and my phaco. My irrigation is not a part of my phaco probe, but my irrigation is in my left hand. But the phaco probe is just removing. It's just emulsifying and removing. And I'm using irrigation to keep the anterior chamber flat. And I'm using the fluid waves over here, which is my manual irrigation, to bring the nuclear fragment right onto the phaco probe. And with good torsional and good followability and moderate parameters, good knowledge of machine, I'm able to make sure that the entire 3 quadrants of the nucleus, which was lying in the capsule inside the capsular bag, was removed without having any fragment drop down into the posterior cavity. And I could do that because of splitting my irrigation and my phaco probe. Now, like the previous surgery we discussed, I put a toric IOL, I dialed it into place inside the capsular bag by enlarging the incision and going slow with the manual delivery. But I decided to do a reverse optic capture in this, where the optics or the haptic is inside the capsular bag, but the optic is prolapsed out of the anterior capsular margin so as to lock the lens into place and make sure that it's dead stable and does not tilt, decenter, dislocate later in life. Just to make sure, it is important to make sure that there's no vitreous left behind. So I use diluted triamcinolone in the anterior chamber to look out for remnants of any vitreous. It's also needless to say, you have to suture these incisions because there's a situation of compromise. And I prefer to use 1 or 2 sutures on my main incision. I'm removing whatever little viscoelastic was remaining behind and also removing the triamcinolone. Again, whatever triamcinolone is left behind in the anterior and posterior compartments, if at all, is going to prevent further inflammation. It's also a good idea to hydrate your incisions with your irrigation in place, because the moment you remove the irrigation, the entire lens tends to luxate anteriorly, and that can cause your, if at all you've done an optic capture, to slip out. So I keep my irrigation in place, hydrate the side port, and once I know that my chamber is formed and hydrate the main port also, then I will remove the irrigation from the bimanual IA out of the eye, because when 2 out of 3 incisions are tight, the chamber will not collapse and I will have a solid, stable anterior chamber. And notice now I'm removing my, finally I remove my the irrigation probe, which was working like an AC maintainer. So this is how the patient looks at the end of the surgery. I'm just trying to check the lip of the wound, and this is how the patient looks a few days after the surgery. Yeah, this is the follow-up 6-9 at 6-month follow-up, well settled 6-9 unaided patient, and a very happy outcome for a very unfortunate incident that happened intraoperatively.
So,
wonderful video, Samresh. Lot of learning and truly amazing. But I have some questions for you. Could you stop sharing your screen?
I stopped.
See you. Yeah. So the
the screen share is stopped now, madam?
Yes.
Yeah, stop. Very nice video.
Very nice. Yeah, Samresh, what I wanted to ask you was, rather I will ask the expert panel, you are all waiting to be challenged. Now, when you see a new PCR there and the nucleus in the capsular bag, the first thing which all of us would think is to get the nuclear pieces out of the bag and then attend.
There is, I think, some problem with her net, as she has said.
Doing a pass with me. Could you all hear what I said?
No, actually, there was some problem with your net.
Yeah, no problem.
No. What I wanted to say was that normally we would have liked to remove the nuclear fragment out when the PCR is there, gently, carefully. But he let the nucleus be in the capsular bag and went to do a pars plana vitrectomy. Okay, let me start with Mohan. What would you think?
I think exactly right. This is a fantastic message I want to give everybody. When you have a PCR, don't be in a hurry to pull out the phaco probe, number one. Fill up with the viscoat. And as soon as you fill it up with viscoat, obviously the vitreous is going to be there. Put tricot first. Stain the vitreous and do a bimanual anterior vitrectomy, or you can go posterior vitrectomy as whatever you're comfortable with. But remove the vitreous first. Then fill that area with viscoat, and then you can go ahead with the removal of the nucleus, as what he did. This is exactly. Don't be in a hurry to remove the nucleus in the presence of vitreous in the anterior chamber. That is going to cause more problems in the long run. Traction on the vitreous base, retinal detachment, retinal breaks, all these problems can occur. Samresh, beautiful video, very beautiful teaching video.
Dr. Agarwal, Virendra Agarwal, are you there? Dr. Virendra Agarwal, are you there? Okay.
Yes, I am here.
Yeah, Dr. Virendra, would you have thought of using a IOL scaffold in this particular case? Would you have done a vitrectomy, got the nuclear fragment forward, placed the IOL in the sulcus, and then completed? Because you can never be sure whether some of the epinucleus could go into the vitreous at this point of time. Could you have handled it a little differently, or would you do exactly the way he did?
This way is also very good, and you can handle by IOL scaffold also is very good. But the issue is the IOL scaffold is the 3-piece. So toricity is not there. That is a one big issue right now we are having. So if you want to really implant and need to implant the toric lenses, then you cannot use the IOL scaffold the way you want. And there is no sense in using 3-piece and cut it and out, take it out, and then use the toric lenses just for scaffolding. So this is nicely managed. And good message is that the vitreous need to be respected. Vitreous need to be managed before doing further maneuvers. Because if you maneuver with the vitreous in AC, then you will enlarge the tear. You will have more of the products of the vitreous. So vitreous need to be addressed first. That is very, very important. Here I want to add on. I want to add on my experience with some of the lenses which are having optic haptic angulations. I am putting them in the sulcus and having the optic capture as a 3-piece lens, and touch wood, till now I didn't have any complications. But this cannot be done with the lenses which are not having angulation, like some of the companies have. The plane lens means the optic and optics are at the same plane. In those cases, you can do a reverse capture. But I still feel if you have something like an option of optic haptic angulation toric lens, then in these situations, they'll serve better.
I'm not aware of which single-piece lens comes with the toric lens coming on an optic haptic.
From the biotech company and from the Johnson & Johnson, both are having angulation, single-piece lenses. One is having 5-degree angulation, one is 6-degree angulation.
Chitra, can I add
no financial interest?
Yes, Mohan.
Samresh, I think the removal of the nucleus with an irrigation separately, I'm not sure, because see, once you remove the vitreous there, and you put viscoat, right?
Yes.
And use a low flow rate and low, of course, Centurion, you have the advantage of active fluidics. So you can reduce the IOP to as less as 20 or 30 and go ahead with the beautiful removal of the nucleus without disturbing, because once you have removed the vitreous, the tear is not going to enlarge at all. And the viscoat will go on a scaffold that prevent that this thing from going at. I don't find any sense for the separate irrigation, because you're going to heat up the phaco tip there, okay? Because there's no irrigation there, no?
So what the reason I did it is because the PCR was right in the area of the phaco area, and the irrigation currents were going in that direction only. So by removing the irrigation, I dissociated the flow of fluid in that area.
Yeah, I got your point. But when you're doing the phaco, there is no irrigation through the phaco tip.
No, so but there is aspiration happening. The phacopropyl get heated up if there is no aspiration happening and there is occlusion at the phaco tip. But so long as material is flowing through the phaco tip, the fluid going out will cool the phaco tip at the same time. So heating generally will happen when which is blocked.
Yes.
Mohan, when you use the separate irrigation, you had some advantage. It works like a third instrument in which you can have the flow over the iris plane level or above the rexis. So it is not disturbing the vitreous. That is one big thing. He has done good way. The second thing, the case was very soft. So even you don't require a phaco power. So in which case that you don't think about the phaco burn or the tip getting heated. And once fluid is there, which is moving, definitely burn is not an issue, or the heating of the tip is not the issue. Viscot is really a big thing for this kind of things to plug in the area of defect. So that is a one good thing. Methyl cellulose is not enough. So you have to use
viscot is the
viscot or some, yeah.
And of course, Chitra rightly said, IOL scaffold has got a huge role in this particular situation.
Yes.
I would have done an IOL scaffold also, but please make sure, okay, of course, if the toric lens is a different issue, multi-piece we have to put, but IOL scaffold, don't do it in the absence of, without doing a vitrectomy or removing because sometimes it's very difficult to remove the nucleus and epinucleus and the cortex also. So make sure that if you remove the vitreous and everything, clear up that area, then you can put an IOL scaffold.
Dr. Rajan, there is one more point I want to add.
Yes.
When you are doing the last part and you're worried about removing the irrigation port and chamber collapse. So once the eye is vitrectomized, you can, what we do in fluid gas exchange in retina surgery, we can do same thing in anterior part also. So you put an air bubble, and that air bubble takes care of the space, and the eye does not collapse. I have tried it many times. And believe me, air is not as harmful to endothelium as has been mentioned. So I think if there is an issue of wound leak, or if you're not sure about the chamber stability, inject air. It gives you a lot of stability and time, and then you can do hydrodissection to the wound, and your chamber gets stable.
Okay. So there were different thoughts. So thanks a lot, Sandesh. Extremely good teaching video. Need a real big applause. We shall now go on to our next speaker, Dr. Ekta Rishi, who's going to show a series of wonderful videos. She was a senior consultant doing extremely well in Shankar Nethralaya, and then she moved on and and from the way her videos are, I can imagine that she's doing phenomenally well where she is. An exemplary surgeon, and she's going to show us a range of videos to drive home a point of, again, past planar vitrectomy. On to you, Dr. Ekta.
Hello, Ekta. Hi.
Can you share your video, or should we share it? No, yeah, she's sharing.
She's in the US, no?
Yeah. Ekta, you unmuted?
Okay. A big hello to all, and thank you, Dr. Chitra and ARC, for the opportunity today. And it's a pleasure always to be on this platform. I hope you're able to see my screen.
Yes. It's dark. But I think, yeah,
Right.
she's got the video. You start. You start.
Yeah,
your
start.
Right. So basically, I'm just presenting 4 cases which are of traumatic zonular dialysis. And the difficulty of zonular dialysis is increasing from case 1 to case 4. The first case is with an iridia. The second case goes on to a higher level of zonular dialysis. The third case goes on with a more higher zonular dialysis. And the fourth case is with iridodialysis as well.
Zonular dialysis management in traumatic cataract. Case 1. It's a 2 clock hour dialysis with an iridia after capsular rexis and phacoemulsification. Think about an iridia lens with placement in the bag and a good pars plana vitrectomy to look for cortical segments which have flowed through the zonular dialysis. The case 2 has scattered sparse zonules with a relatively centered lens and a lot of iris damage. After rexis and phacoemulsification. An IOL can be placed in the bag along with an iridia CTR in the bag. Post-operatively, it gives good result. Case 3 has 6 clock hours of inferior zonular dialysis. Rexis is a bit challenging. So is the phacoemulsification. Use iris hooks for a good visualization. Making a scleral groove and using straight 10-0 proline needle to fixate a Sioni ring. The suture is passed through the Sioni hook and the CTR is placed in the bag. This is the second pass and it is fixated to the sclera. A foldable IOL is placed in the bag. Again, a limited pars plana vitrectomy and a good fundus view helps this patient. Case 4 is a traumatic zonular dialysis along with iridodialysis. A scleral groove is made, limited pars plana vitrectomy, and 10-0 proline is used with a straight needle to do the iridodialysis repair with Mackennal sutures. Iridodialysis repair shows that the lens looks pretty centered now, and the anterior collapse of the formed vitreous was tilting the lens. Pars plana vitrectomy is a better choice in such patients. The lens was managed with aspiration. Always think about iridodialysis repair in the same sitting. Thank you.
Amazingly wonderful videos, Dr. Ekta. Each has a teaching pearl with it. But for the sake of discussion, to bring a lot more from the wonderful video, I have a series of questions which I would want Dr. Manisha, Dr. Malay, Dr. Agarwal, and Mohan Rajan to comment on. My first thing was in your first case, I would, Mr. Sunil, could somebody else,
Sound is there, no?
please everybody mute yourself. So Dr. Cyrus, we are able to hear you. Dr. Cyrus, could you mute yourself? Somebody has to call Cyrus, I think.
I'll call.
Yeah. The first thing I felt was the first case, CTR could have been. Mr. Sunil, could you tell Dr. Cyrus to mute himself?
Can we
admin can mute him.
Can mute him. Admin can mute him, please. Sunil, can you mute him?
Because you're. Yeah. He's muting it.
He's not.
No pressure.
He's not caught on.
Hello, can you all hear me?
Yeah.
You have to not hear you. You have to mute yourself. Yes. So the first case was that if a CTR had been placed, probably she could have avoided some cortical, some stuff going into the vitreous, because from that small area of zonular weakness, it's just my thought. Would the CTR have been placed earlier on? The second question I have is, such a large aniridia IOL, you need a very large incision, no, to place these lenses. But then, could you have placed these aniridia segments and then place the IOL? And again, when you place the aniridia CTR in one CTR, if you place, does it not make sense to place another CTR also on the other side to have a proper stabilization of the capsular bag? These are some of the things. And the third case, my question was, instead of using a Sioni ring, it was a small area of dialysis. We could have done easily managed with a CTS2. What are the challenges in each of these? Could you, Mohan?
Yeah,
Manisha,
I think Ekta, all the videos are really fantastic, incredible stuff. I will tell you. I have the first case has been managed very well. I would agree with you, because the aniridia lens itself was, because it's a very localized 1 or 2 clock hours dialysis, if I'm right. The fourth case, no. The fourth case is something I will do differently, because you have the hydrodialysis there, huge hydrodialysis, and you have got a mature cataract also. What I do is, normally I put iris hooks and retract that iris to the periphery. Okay, I keep that in the periphery, in the angle. Okay, then I go ahead with the cataract surgery. But during the, if you do the hydrodialysis repair, sometimes you can rupture the anterior capsule. Of course, you are a fantastic surgeon, but I'm just telling you, for an average surgeon, they can even touch the capsule and the whole thing can go for a 6 after that, and the whole battle is lost. So what I would do is, I will do the retract the iris with the iris hooks, keep it in the periphery, take off, manage the cataract, put an IOL, and then I will do the repair, the same fashion as what you did. Yeah.
Yeah. Dr. Manisha, you have anything to add?
Yes, ma'am, really beautifully operated. What would be the ideal choice of IOL in these patients? Plus, we get
can we look at
we have a series of patients, young patients, who come with very weak zonules or absent zonules in Marfan syndrome cases. So they're young patients, and they sometimes develop cataract early. They also require surgeries. In them, we are trying to use similar manipulations. So what would you recommend as the ideal intraocular lens for these patients?
Thank you so much for all your comments. And the first thing is, I will like to address is the Marfan syndrome cases, because these are the patients with abnormal zonules. The pathology is with the zonules. So the cases I've shown are all traumatic zonular dialysis. So they have other healthy zonules. But in Marfan's, I don't consider fixating these lenses, because it's better to just remove them. Ultimately, they are going to fall down.
Yeah.
Correct.
100.
And they have a high chance of retinal detachment. So it's not an ideal condition to be fixating the IOLs and doing so much manipulation. Coming back to Dr. Chitra, the first case, because it was an old trauma, slightly older trauma, there was already fibrosis which had set in. So you could see a small area which was retracted, and there was a lot of aniridia as well. So even a CTR would not have helped, because this was not moving at all. There was fibrosis, but there was an area which was open, and through that it just had to flow.
Yeah.
But maybe more viscode there would have helped, probably.
Yeah. And how do you take care of the pigments in the aniridia iode, or the safety of the pigments from getting?
Right. So, yeah, we have been looking at this, but so far, so good, because we are not seeing much of pigment dispersion and discoloration. And these are the lenses which we use from IOC. But they are relatively, like, we didn't face much of glaucoma and pigment dispersion.
Sometimes the bleach. I have had a couple of patients when the bleach over a period of time.
Right. But presently, the lenses which are coming are looking better than before. And like, I have some 7 to 8 years of follow-up on these patients, and we didn't see much of pigment dispersion, luckily. Because if we are going for Marshall lens and all, they are definitely more expensive, and people are not able to afford them better. The iris segment, same ways, if we are going for the soft silicon segments and we are stitching, again, the possibility of glaucoma is much higher with these patients. So it was much more easier here. Yes, if I would be having the CTR at that time, CTR would also have been an option for the first case, but I was not having it there. And aniridia IOL was already ordered for this, and it was working well for him. So that's the reason.
Yeah, yeah.
Aniridia CTR, yes, agree. 2 CTRs are the ideal,
yes,
but it becomes more heavy. So the manipulation really becomes more difficult, as you have already an IOL inside, then you are putting another CTR. And ultimately, this was a patient who was not affording much, and it ultimately fibrosed and created something like an iris.
Yeah.
So something helped. He was not affording another CTR. That's the reason. But yes, ideal situation would be to put 2 aniridia CTRs.
Absolutely.
Then the third thing was about the traumatic iridodialysis.
No, CTS. Iridodialysis, I was going to ask anyway. Mohan told the alternative, which is what I wanted to be highlighted, that could have been done like the way he mentioned. But CTS against CONE, your thoughts?
Yeah, because I have probably more experience with CONE. So I've been in that position that I've been doing regularly these cases. So probably that's ultimately immediately available, and you go ahead and do it off. Yeah. So that's the reason. Because I work more with vitreoretinal surgeries. So I don't happen to, these are the things, like, you keep doing scleral fixation, and CONE fixation is not something very different from it.
Yes. No, wonderful videos, Ekta, really wonderful. So and the very intelligent way of keeping a pars plana open, so that, you are able to deal with the vitreous from behind and keep the posterior surface.
She also made sure every time, she went into the posterior segment, had a look at the posterior segment, which is very important. And especially with Marfan syndrome, I also believe that a total vitrectomy, almost you do it off. Better, because high incidence of RD, because when you do a lensectomy, and not only an anterior vitrectomy, but do a good vitrectomy. Yeah.
Thank you very much.
If you look at the zonular pathology, in cases of zonular pathology, be clear, like, this is ultimately going to be progressive.
Yes. Yes, and better to fix
Dr. Ekta, up to what amount of zonular dialysis you will not use any support, like as Dr. Chitra was telling, that capsular supporting hooks you have not used. Don't you think it would have been more useful in stabilizing the capsule?
Yes, it would be, but sometimes even it tears off the capsule. So in my hands, I have not used it much. That's the reason that I don't usually go ahead with it, and I'm able to manage it, because I have placed this CONE usually early in the stage. Most of the time when there is some cataract, that time you place these hooks, and then you handle the lens matter later.
And up to what amount of dialysis would you still try to salvage the capsule? Because what happens, people you must have seen, the entire capsular lens back goes down, and people have removed it from the retina.
Right. So being a vitreoretinal surgeon, any amount of dialysis, I first give a try. And even if it falls down, I know ultimately I'm going to do the vitrectomy, and I will remove it. But if I am able to fixate it well, I will still try to do that in a traumatic case.
I think the broad cutoff will be around 180 degree.
180.
If you have less than 180 degree, probably you can manage to a certain extent with a Cioni or a segment or whatever it is. But beyond 180, then what that's my cutoff, broad cutoff. There can be exceptions to the rule, but broad cutoff is beyond 180 degree, and I go ahead with the removal of the lens and scleral fixation. I do usually glued IOLs for these patients.
Dr. Rajan, my concern was in such subluxation, doing capsulotomy is very difficult.
Yes.
So,
and nowadays I use the femto platform, which makes life very, very easy for us. Fantastic. It is really.
If you don't have the femto platform,
for people like us.
No, you can initiate the rexis and then use capsule hooks to give stability and then move on to complete.
Something like a bimanual rexis you have to do.
Yeah.
Bimanual rexis using micro rexis forceps on either side, holding the capsule on one with this thing and then tearing it with the micro rexis forceps.
The only thing will be to keep in mind is the more the zonular dialysis, the centration of the lens is going away. So from where you are starting the rexis and ultimately where your rexis will be, you'll have to figure it out.
Yeah.
That's why at the end of the thing, when you put the lens in the bag, then you need to probably, at that time, the rexis will be eccentric and you need to probably enlarge the rexis and make it centric at that time.
Exactly.
Thank you very much, Dr. Ikta. Really nice to see you after a very long time.
Thank you so much.
Wonderful videos. It was a treat.
Ikta, say hi to Pukraj.
Yes.
Definitely. Thank you so much.
We miss you both.
You added color to our ARC webinar with the variety you brought in. And thank you. Do stay on with us. We shall now go on to our next speaker, Dr. R.K. Bansal, who is the Medical Director of Bansal Eye and Retina Center, Chandigarh. And again, a very dynamic surgeon and is a very important figure in the North Zone Ophthalmic Society, and not just that, a national figure too. And he's going to be telling us the challenges of a torn rexis in a mature intumescent cataract. On to you, Dr. Bansal.
Yeah, thank you, Dr. Chitra, for a wonderful introduction. And thank you, ARC, for giving me this opportunity. As you mentioned, I am going to talk about phacoemulsification in a torn rexis whenever we face the problem of a mature intumescent cataract. All of us know we face this problem many a times during cataract surgery. That patient comes late and there is already a swollen mature cataract, as you can see in this video. So there is a necessity to stain the capsule because there is no red glow in these patients. So trypan blue was used to stain the capsule. And then a high viscosity viscoelastic was used to push the capsule back. And you see, just when I puncture, there is a leak of the liquid material. So what one can do is to aspirate the cortical matter so that you bring the intralenticular pressure little down. So I was sure that this patient will do a good capsulorhexis. So started with a nice capsulorhexis with a capsular forceps. And you can see here, just on this side, there is a tear of the capsule and it is going to extend into the periphery. So this is a dilemma we face. If we don't face a Argentina flag sign, sometimes we can face the extension of the rexis right into the periphery. So here we have to see whether we are the tear is extending into the posterior capsule or not. So one can see the motility flap sign and see the other evidence which will be there if there is a extension of the rexis into the posterior capsule. So usually using low parameters here, because I already know that there is extension of the capsule into the periphery. So we have to be very manipulative and see that we can bring out the nucleus into the anterior chamber and do the chopping of the nucleus here and do the phacoemulsification. So this patient, the lens was not very hard. It was just grade 2. So it was possible to bring the nucleus out of the bag and then do the phacoemulsification. So using very slow parameters and carrying on with the phacoemulsification. And usually these patients don't have much loose cortex. So some aspiration of the cortex may be required in patients. So again, one has to be very, very careful. Use very low parameters. This is the part of the epinucleus. So this was a single piece IOL which was arranged for this patient. And it is always possible to put the lens in the bag, but only thing one has to keep in mind, that the haptics of the lens are perpendicular to the area of the tear of the, or the extension of the anterior capsule. So this patient had a multifocal lens. So here I'll further rotate the lens so that the haptics are in a different direction. So this patient I can see, because of the, there is a little bit wound burn. So the patient required one single suture so that there is a stability of the anterior chamber. So single suture was applied to maintain a nice anterior chamber at the end of surgery. The pupil could be constricted with using intracameral pilocarpine. Aspiration of the viscoelastic at the end of surgery. So one can really do a nice implantation in, even if there is extension of the rexis. So extension of rexis can occur during the CCC. It is more so common, especially if there is a mature intumescent cataract. So we should try to control that, we prevent the further extension of the rexis, and we can look for a flap motility sign so that we know that the extension has not gone right into the posterior capsule. We use low parameters so that the fluidics in such a way so that the fluid pressure is not there on the capsule, and the further extension of the rexis can be prevented. And always try to do a fragment chopping which is outside the bag, and always orient the lens perpendicular to the torn rexis.
Thank you very much for all. Yes, thank you very much, Dr. Bansal, for your pearls of wisdom. But for the sake of discussion, we are going to tear it up piecemeal. So what I would, I felt that if you had not gone, of course, you're a very experienced surgeon. I've seen so many of your live surgeries. The thing is, if you had not gone to the main incision, you know, you end up shallowing the anterior chamber when you go to the main incision to make your rexis, and in these total hypermature intumescent cataract, rexis extension can occur. Had you gone to the side port and had a snug fit micro forceps and made a small round rexis and then nicked it and enlarged it, it's a greater chances of it being successful, but you did manage very well. Before we go on to discuss other ways of intumescent cataract, I would want to ask Dr. Malay and Dr. Manisha and Dr. Virendra Agarwal and Mohan, what would be the challenge we would have by placing a multifocal lens in these eyes with a torn rexis? Would there be any challenge at all in the first place?
Yes, so I think the moment I saw the multifocal lens, I started having a question because you see, once the capsulotomy is not centered and it's torn, we are not sure about centration, and there are concerns about multifocality in itself. I would prefer not to use a multifocal lens. That's my take.
If it had been a smaller area of rexis extension and 3/4 of the capsule overlap was there, probably we could still think. Mohan?
First of all, why did he get a rexis extension in the beginning, in the intumescent cataract? There are many ways to avoid this. One is to, you able to hear me?
Yes, yes.
One is to put in a 27 gauge or a 26 gauge needle into the anterior compartment, try to aspirate the fluid, and then go ahead with the rexis. Of course, you need to use things like a soft shell technique, like Hyalon and Viscot for this particular to prevent. The other thing, of course, you know, what I'm going to talk about is a punctorexis, which I'm doing for all these patients. Patients can afford, I do the femtorexis. So once you are not able to avoid that, then you have to see the Bansal has managed it very well. Once you have a rexis tear, I would not do any trenching at all. Okay, I will do direct vertical chopping, because the vertical chopping, what you do is you just go in, bury your phaco tip, lift it slightly from the back. Okay, not too much into the anterior chamber. Of course, you need to put replenish with Viscot now and then to prevent. I don't mind losing some endothelial cells, but I don't want this extension of this rexis. Of course, a flap motility sign is one way of doing it, and a strict no to multifocal lens, especially when you have tears on both sides. And in this particular case, a multifocal lens, I would not have used. I would have just put a regular lens for this, unifocal lens for the patient.
Dr. Rajan, just one comment. As far as this Argentina flag sign has been discussed so many times, you see, and I am lucky not to see many. What I do, I universally use methyl cellulose. I never use this high viscosity thing. I just make a central puncture. Most of the time in these capsules, the fluid comes out in the antechamber, then it gets deflated. It goes out of the incision. And then you see the rexis becomes very easy. And
No, it's not as easy as you mentioned. Please understand, Malay, there are 3 types of mature cataracts. I have done a lot of work. In fact, I can do a thesis on this, actually. But there are 3 types of mature cataract. One is the type 1, type 2, and type 3. Type 1 is the most dangerous. The intraventricular pressure is very high. As soon as you touch, it will go to the periphery. Okay. And that is very, very typical. So even if you do a smaller rexis, sometimes many people have advocated that. But the only foolproof method today is the femto platform for this type of cataracts.
So we get thecomorphic glaucomas, and the whiter the cataract, the lower the socioeconomic status of the patient. So sometimes all they can afford is, even if you puncture, like you're talking about the type 1 cataracts, so anyway, they're thecomorphic glaucomas, pressure is above 50. The moment you just puncture the capsule, you get this fluid, so you can still manage, because after that, again, put viscoelastic, stain the capsule initially. So staining of the capsule helps, more viscoelastic, and like ma'am said, try to make a smaller rexis. These are things that we can do.
And of course, use the side port to use a micro rexis forceps. And
people have also suggested capsule
that you make a little curvilinear rexis. You make not a linear incision, make it little curvilinear, change the direction, and that itself could prevent the thing.
This is what I did today. Also, I had another patient with a mature intermittent cataract. So rather than giving a linear incision, I just curved the incision.
Yes, it makes
and very well after that could complete the rexis.
Yes.
As for the micro forceps is concerned, they have to be handy, because I was not having handy those micro forceps that time. So sometimes you have to use whatever is available, so that you can do a good rexis.
Yes.
So another point I think about the multifocal, yes, I do agree, but this patient we have arranged a multifocal lens. And if we are able to cover the margins, as Dr. Chitra also mentioned, that if we know that at the end of surgery, we can cover the margins of the lens with the capsular, then I think these patients do well. And this patient, in fact, did very well after that.
Yes.
But any possibility, if there is an extension towards the posterior capsule, then definitely we should try to use a 3-piece lens.
Yes. Thank you very much, Dr. Bansal. We shall now go on to our next speaker, Dr. Dharmendra Nath, who's again a very leading eye specialist in Agra, one of the pioneers in cataract surgery from Agra Eye Center. And he is going to be showing us a new instrument by which he does phaco in a pretty unique manner. On to you, Dr. Dharmendra Nath.
Thank you so much. Is it there now?
Yeah, you have started sharing. Yes.
Yes, thank you so much, madam. And definitely so many thanks to Dr. Mohan Rajan. And he visited my place once about 2 years back. So this is the new technique of the aligned chopping in phaco. Actually, why this idea came in my mind, because most of the time, what happens, the nucleus spins. Okay, I just want to share, then I go to the slide share now. Then, so what happens, you just see when you want to chop this hard nuclei, especially, they start spinning. And most of the time, I mean, you get a real trauma to the capsule and what you have made the CCC. So once again, just see this, trying again, and chopper is applied to the periphery and try to chop it. Though it chops, but it spins more. The edges are not so clean cut, but it is. Are you listening?
Dr. Nath, we are not, your video is not.
Video is not playing, sir.
Oh.
Video is not playing.
Okay.
So.
Can you stop sharing and share again?
Okay.
Open the video.
I'm just opening. But my video is
हाँ, आपके में रन कर रहा होगा। हाँ
हाँ हाँ,
अभी आपको
अब आया?
अभी आप
नहीं।
दिख रहे हैं। We can see you.
No, no,
Oh.
आपका वीडियो नहीं आया. That time you played, no?
You open the video.
Wait, just going.
First minify.
Now.
First minify. This is a zoom.
Now this is it okay now?
No.
No, we can't. Doctor, first open your presentation, then come back to the Zoom window and then share screen.
Okay, I just try once again. Now I am.
Mr. Sunil, can we share his video? It's a good video which he's showing.
Yeah, let me just share it from my end.
Yes.
Dr. Dharmendra, stop sharing. Let Mr. Sunil share your video.
Okay.
You can talk along with it. Yes.
Is it there?
Yes, it's there.
Yes. So most of the time, actually, what happens that nucleus start spinning. So for that sake, what we have done is the big CCC is there, and the central, from the paracentral area to central area, crater is made. And from the side about 30 degree away from the main port, the aligned chopper is introduced inside, and we just go to the high vacuum and very low pulse phaco, very little, and go to the periphery, chop it, and it clean cut. There is a clean cut. I mean, one hand is stable and another hand is splitting the whole of the nucleus in the half hemisphere. And again, you just rotate the nucleus, and the left hand, this chopper also facilitate in rotation also, and again it chops from the periphery. It gives less stress. And see this case also, this is the hard cataract, and we are just holding the one half of the nucleus and chopping it from the periphery. And this is again rotate the nucleus with the same instrument. It is angled chopper about 30 degree from the main shaft, and go to the periphery, chop it, and it gives a clean cut chop without doing any stress to the zonules and without damaging to the anterior and the posterior capsule. So again hold it and chop it. This is how we just do it. Again rotate it. It facilitates in rotation of the hard nucleus also, because it is angled. Go to the periphery, again hold it and chop. This is how you can do the multiple pieces, and after doing the multiple 4 pieces, or you can chop into the 8 pieces or whatever you. So this angled chopper is definitely is added advantage in chopping the hard nuclei. Soft nuclei you can take it with any of the chopper, but hard nuclei is difficult to deal with this. Regular choppers. Now, do you have the another? This is how we are doing the multiple chops. Now, see this is the, from your side, and hold the nucleus in the center of them doing the good CCC in the center. And you see the aligned chopper, the force is towards the tip, not towards the other side. Just hold the nuclei, and this is the sharp chopper and this is how we just separate it, giving the less stress to the zonules. So this is my basic aim and idea is just to facilitate and make easy chopping, and nothing else. So that's why the name the aligned chopping is giving, because the force is towards the tip, not towards the outside. So most of the chopping technique is not like that we are chopping outwardly, not to the centrally. So this is towards the tip.
Wonderful video, wonderful videos rather. Could you describe your chopper length and dimension?
Yes. This is actually regular chopper, which is about 30 degree bend, about 2 millimeters away from the tip. That's it.
You said
from
it's
the
a
2
sharp
millimeters
chopper.
away from. Yes, Rajan.
Sir, you said it's a sharp chopper.
Yes, sharp chopper is for the vertical chopping, and the blunt for the peripheral chopper.
That's what, because if it's a sharp chopper, you cannot use it for horizontal chopping.
Yeah.
Yes, yes. That's what I told you. This is for the vertical chop, and the horizontal chop is a blunt one.
Okay.
And that is, yes.
It's a little longer, no? The tip of the chopper.
It is about 1.5 millimeter long.
Oh, only 1.5. Okay.
No, well, the only problem I envisage is that because when you have a very brown cataracts, there is nucleus and more nucleus, and there is no cortical cushion.
Yeah.
Okay? The entire bag is filled up with the nucleus.
Yes.
And then when you do, that's why I prefer a vertical chop in these patients. Okay, if you do horizontal chop, you need to make a rexis little bigger and then go from the periphery.
Periphery to the center.
The problem is when you go underneath the rexis and come from the equator, which is you are doing in this align chopping with this blunt chopper, then there's a possibility. I'm just telling a possibility. You're a good surgeon. For an average surgeon, there's a possibility you can damage the zonules, even the PC, because it's a little blind technique going underneath and coming out. If there's a cortical cushion, no problem at all. If there's no cortical cushion in the very brown cataract, you may have some problem. I prefer vertical chopping for these patients.
I missed telling you, because in the hard cataract, because we are holding the nucleus with a high vacuum, so we just when we are doing the chopping, we just increase the bottle height just to have a more space in the antechamber.
Okay.
At that time,
I want to make one comment.
No. Okay.
Yes.
We have many more surgeons to operate. Make it brief. I just realized that it's already 7:50. Yeah. So, would you want to add something? Shall I go on?
30 seconds. You see, Dr. Mohan and Dr. Dharmen, both are my very good friends. You see, when we do the radial part of the chop, we actually don't divide. It's only when we do lateral separation, the nucleus gets cracked. That is one thing which I have found that phaco surgeons have not realized so far.
But in this chopping, what we do, we just hold it and we chop it from the periphery to the tip of the phaco. So this is the exact thing of doing the chop.
Yes.
So that is exactly the point. When you are bringing, actually you are not dividing.
Yes. No. That's what I say. From the periphery to the center, we are actually chopping it. You just see the clean cut margin of the pieces.
I think fine. आपका बहुत अच्छा डिवाइस है डॉक्टर साहब, हमने यूज किया हुआ है, बहुत ही बढ़िया है. It's fantastic.
Now,
thank you so much.
We go on to Dr. Balla, who's I didn't know, Dr. Balla, you had joined, and you should have.
Sorry, ma'am. I just joined. I joined very late, but I think I just listened to one more talk before I take up, ma'am.
Hi, Balla.
Hi, Dr. Mohan sir. Good evening, Dr. Male, Dr. Dharmendra sir.
Good evening.
Good evening.
Yes. Hi, yes, Balla, doctor.
बस ठीक है सर, आप कैसे?
We will talk later. We will go on to Dr. Vipin Sani, a senior eye consultant from Kausalya Devi Eye Institute, Uttar Pradesh. And he is going to be showing us a very interesting video and lot of learning again in it. On to you, Dr. Vipin.
Yes, ma'am. Where is it gone?
You all had shared, no, in the beginning.
Where's Zoom gone?
Zoom, you would have minimized it or what? You click on the Zoom icon on your.
Yeah, I am clicking it.
Mr. Sunil, can you help him?
Yes, ma'am. I'll play, ma'am. I'll play.
Play the video. That would be better.
Okay. This is.
Dr. Vipin, let him play the video.
Okay.
Because, it becomes late. Actually, in fact, I think, Mr. Sunil, you could play the remainder videos so that, we don't lose time on that. Dr. Vipin, you could start.
Yes. I'm presenting IOL scaffold after PCR. This was a case fellow was doing. He was doing 4 tunnel method and then chopping one by one. So everything was going well. When the last piece came, because of sudden collapse of the chamber, there was a PCR. So before removing the phaco probe, I asked him to put the methyl cellulose first inside the eye. Then the probe was removed and case was taken by me. We took all the pieces of nucleus over the iris and inserted a 3-piece foldable IOL inside the eye. Everything was going well, but IOL turned upside down suddenly. As the lower haptic has gone into the sulcus, I rotated the IOL and put it over the iris. Then I took this small piece of nucleus by phacoemulsification, and all the small pieces were removed one by one. It was taken care that chamber should not get deep suddenly or something like that. Then I toppled the IOL using 2 instruments and dialed the haptic into the sulcus. Vitrectomy was performed. Earlier we was not using this tricot. Nowadays we are using tricot. And wound was hydrated and everything was very well. Similarly, there is another case. In this also PCR, I took the case after PCR happened, deposited the pieces over the iris, used 3-piece foldable IOL, lower haptic going into the sulcus, and I dialed the upper haptic over the iris, collected all the pieces over the IOL, and phacoemulsification was done using IOL as a scaffold. It was taken care that chamber does not collapse or get suddenly deep. Phacoemulsification was done. Some cortical matter was removed, vitrectomy was done, and then later on IOL was dialed and wounds were hydrated.
Thank you. Thank you very much, Dr. Vipin. You showed us different situations of IOL scaffold. So we are coming back to this. Now we do understand the challenge which you showed us in a 3-piece which is used as IOL scaffold, how it can have a very forceful opening, unfolding.
Yes.
Sometimes you can even push the nuclear material down, and in your situation even turned upside down.
Yeah.
And Mohan had said in an earlier situation that if you have a nuclear matter, like in the case of Samresh's case, there was less of vitreous presenting. So he could actually do without an IOL scaffold. But there are situations where there's so much of nucleus matter, you can't be doing a vitrectomy at that point of time to salvage, do clear the vitreous, the nucleus would have gone down completely. Sometimes you may have to introduce a 3-piece IOL, get the pieces onto the scaffold, and then carry on. These are just thoughts which I'm putting forth for 1 or 2 discussion points before we go on to the next speaker.
Absolutely, the vitrectomy has to be done earlier.
Yes.
Before the tricot, use tricot, do a vitrectomy, and then
nowadays we use tricot.
Yeah, do a vitrectomy. Whether you use tricot or not, do a vitrectomy, then put the IOL, and then remove the nucleus.
Dr. Mohan, there is a question.
Yes.
Suppose if we don't flip the lens, how it will affect the vision? Both are biconvex, almost biconvex.
The multi-piece lens, it doesn't matter.
Yes, because you see the already chamber is compromised. Our experienced surgeons, Indian surgeons are very experienced and they can actually flip it. But if you don't flip also, and if you put it like this also,
it could have
not
been
going to-
done without flipping, but I wanted to
No,
flip,
but
so I flipped it.
I will tell you one thing. Please understand what this ball game very clearly. Once you remove the vitreous there, you don't have. You can just do all the manipulations in the anterior chamber without any fear.
You can
once
clear
you
the
have the
vitreous right in front. Don't go deep down.
Yes,
All
once
the
you remove the
vitreous in
vitreous.
front.
But if you have the vitreous there and you try to manipulate the IOL and you are doing the phaco and you are actually cutting the vitreous also with the phaco, because you do not know the vitreous will be right in front of the IOL when you are removing the nucleus. The nucleus and the vitreous are all entangled. Okay.
Actually,
Vipin is actually a very experienced surgeon, and he
IOS
was
scaffold,
able to scaffold and plate.
IOS scaffold is best when the vitreous is less and the PCR is smaller. When there is a large amount of vitreous and a large PCR, we have to deal with the vitreous and then only look at placing the IOS scaffold. Very learning tips and very well done. We shall now go on to Dr. Jatinder Singh Bal.
Yeah, ma'am. Can I share from here, ma'am?
Balla.
Yeah.
The superstar of Delhi.
Yeah. I'm just going to.
Dr. Balla's video and all the videos.
My video is there, sir. My video is there, ma'am.
Yes, yes. Sunil, can you share?
No, I don't have Dr. Balla's video now.
Yes, can you just wait a minute? And Dr. Balla is also a member scientific committee of AIOS, and he is going to be showing us a different thing from what we have been seeing all along, a different thought to the whole game of cataract surgery.
I'll just share from my side then, if it is not there.
Yes, Dr. Balla, you will have to share. I don't have the visibility.
Okay, I'll share. Is it visible?
Yes.
Is it visible?
Yes, yes.
Yes, sir, yes.
Okay. So, I think it is not playing.
Can we all mute ourselves, please?
It is not playing from here.
No background noise. Mr. Sunil, probably you should mute everybody.
Dr. Chitra, would I be going next after
Yes.
Dr. Balla?
Yeah.
It is not playing. I think my video is not playing here. I had sent it also, ma'am.
Yes, it was sent to Mr. Sunil.
Yeah. Sunil, my video is there because I'm not able to play from my side.
Essentially, the video.
No,
Sunil,
no, this is this is I think.
else.
Sorry.
We shall go on to discuss Dr. Balla's video. He has shown us an opacified IOL and how he cut it and had to remove this IOL.
No, this is not the one.
No,
Sorry. No. Can I send again? Because I yeah.
Chitra, my video is queued. Could I play? Anand here.
We have to either discuss your video or we have to. I'm surprised how Mr. Sunil does not have your video. All the videos were sent to you, Mr. Sunil.
Yeah, Sunil, I had sent long time back. If you want, how do I send it now?
Very difficult. You have to use
Sunil?
Sunil?
Not there.
Mr. Sunil, are you there? Dr. Balla, can you wait? I will call him separately on phone.
Yeah, ma'am. I'll send it across. Meanwhile, you can have Dr. I think Parthasarthi is waiting.
Yes, Anand Parthasarthi. Yes. We shall now go on to our next speaker, Dr. Anand Parthasarthi. You would have to stop sharing your screen, Dr. Balla.
Okay, ma'am. Okay.
Yeah. Who's again a medical director and chief surgeon of the Center for Vision and Eye Surgery, Chennai. And again, a very versatile surgeon with a lot of innovative tips. and he is going to be showing his video to us.
Thank you, Chitra, and I'm just starting the video directly. This is about a customized toric IOL in a keratoplasty patient, and this patient had actually undergone a therapeutic keratoplasty for fungal keratitis 6 months back, and then came back with significant astigmatism with a clear graft, but also with a hypermature cataract. And at this point, we decided to go ahead with the surgery. But if you look very carefully, there is a membrane on top of the cataract, which is an inflammatory membrane. So that was a challenge I was anticipating. Of course, the surgery will be done with the help of viscoelastic and specifically chondroitin sulfate to make sure the endothelium is protected. Now, I did use the Pancho-Rexis, and Mohan Rajan inspired me at that moment of time to actually try this. And because of the thick membrane, rather than doing a simple Rexis, which would have been very tough with the fibrotic capsule, I decided to just make a small opening. And since it was a very soft cataract, in a hypermature cataract, it's actually quite important only to make an opening, make sure it's regular. And then I went ahead with only the IA. And even since it was hypermature, but there was a very thick cortical matter, and it took a bit of irrigation, bit of movement to make sure we could actually aspirate it. Remember, this is 6 months post-surgery. Patient has very less vision. The inflammation has come down. And this, actually, you can make out the pigments on the anterior capsule. As you go around, gradually the cortex actually liquefies, and then you can take it out. It's still a struggle because it's a very it's not like a standard opacified cataract. This is a very, very inflamed eye. It's a more like a uveitic kind of cataract. You can make out that it's a slightly oval rexis. I'm struggling here actually to extend and make the rexis longer, but because it's fibrotic, you do not have any control like you would in a normal cataract surgery. And here you can see superiorly, because of the iris synechiae, I'm still not able to make it large. But then I decided that however large I could make it, this seemed a fairly large enough rexis to actually place the toric customized IOL. We used a customized plate haptic in this, and it had about 8 diopters of astigmatism. We did just remark it, and before we went ahead, remember that the incisions in post-keratoplasty patients has to be a limbal incision. It cannot be clear corneal like we are used to, and it needs to be a more limbal than, or if some patients, some surgeons even prefer scleral incision. And in a 2.8 incision, it's fairly easy to insert this plate haptic. Remember that the leading haptic has to go under the rexis, because it's a slightly smaller rexis than what I would have liked, but a bit of a struggle. We realized that sometimes in a tight haptic, the lens doesn't open as well as you would like. So this part I am struggling with the lens dialer to actually put it in. Now, this is important in plate haptic because remember that the second plate haptic have to go in together rather than trying to dial in like we are used to in a reverse normal J loop or a C loop. That once you have it in place, the advantage with the plate haptic is movement is actually very, very less. You can see it's fairly well aligned. You have a bit of places of iris atrophy, bit of synechiae. And the advantage, of course, is that it's not going to move. That is the residual cortex. I realize I go back in and then try and aspirate those few areas, fibers of cortical material. Very important that you suture these wounds post-op. The graft is clear, the lens is placed. He has about 6/12 vision, which I feel is very acceptable from where we started with a fungal keratitis therapeutic keratoplasty. Thank you so much for your attention.
Wonderful video.
Fantastic, fantastic, Dr. Anand. Unimaginable that in keratoplasty with cataract of such a magnitude, you can give 6/12.
Yeah, how did you do your biometry, Dr. Anand?
Good question. We did repeat it. I did put an image of the pentacam. We did the average K across the pupil, which is a 3 mm zone, and that was taken as the average K. And remember that we are not trying to correct all the astigmatism. The aim is only to give them good, reasonable vision. But we have done good studies on keratoconus patients, Dr. Chitra, and it is possible to get reasonable keratometry readings if provided you take an average K and don't try and correct the whole amount of astigmatism. You're only correcting a part of the astigmatism. I think that's an important.
What would be the formula which you would have used?
In this, this is SRKT. But if you ask me now, this is almost a year plus old. Now we have shifted almost for all cases for torics, we go for the Barrett's. So that usually gives good results.
Anand,
Post-RK.
can I have a question? Can I ask a question? Chitra?
Yes, yes.
Yeah. But I just want to know, because there was Sinike, no? Why you didn't release the Sinike before you did the capsular rexis?
That would be an option, but it's a very thick fibrotic binding. Post keratoplasty, Dr. Mohan, it's not like a uveitic Sinike. These are actually very, very thick, because if you do remember what happens with fungal keratitis is those form over the iris, they go under the iris. So during the first primary surgery, when I did the keratoplasty, I removed all the membrane. But since there are some fungal filaments, and when you're treating with antifungals, there is a fair amount of scarring. So it's not a very simple Sinike, but I felt it was more important in rehabilitation rather than trying to remove all Sinike. And the lens went into the bag, so I decided I was okay with that. But what you're saying, as in terms of releasing to make the rexis larger, is a good suggestion.
Yeah, because once we remove the membrane, normally we don't see these membranes on the slit lamp, but under the microscope we see these membranes. So it's something like a micro level membrane. So once you remove the membranes, the Sinike, some of the Sinike can get released.
This is true in uveitic cataract, but in therapeutic, that part is
obviously it's the inflammation which is causing this problem here in this patient.
Sure. I agree with that point.
Yeah, puncturexis you did well. Only thing is, I find your probe a little tangential. You need to go a little vertical. If you want to punch actually, and also emulsify the nucleus, you need to go vertical, as if you are going into the anterior vitreous.
What are your parameters when you use your puncturexis?
Puncturexis, you use about 50% to 60% continuous phaco power. Continuous phaco power, and about 350, 400 millimeters of vacuum. And aspiration flow rate can be anything. It doesn't matter. So
yeah, I agree. I use slightly, because this is a hypermature, I used fairly lower parameters. My vacuum was only about 100 with about 40%, and I used a longitudinal phaco. So I think the longitudinal phaco rather than pulse or burst is an important tip. I keep slightly lower vacuums because in a hypermature, what is important is to prevent the run out. So 200 works well for me, but experienced surgeons like Dr. Mohan, Dr. Chitra, I'm sure they use slightly higher vacuums.
No, I don't.
Can I make a comment?
Dr. Mohan, Chitra doesn't do puncho, but she punches me.
Dr. Mohan, can I just make a comment?
Yes.
Yes.
Why do we need 50% power? After all, we just have to make it punch the anterior capsule with little bit of the...
No. Please understand. There are two mechanisms for this puncturexis. One is you are using high vacuum. You are pushing the thing and opening up.
That is okay.
Opening
but why power? Why 50%? Why
50% phaco power is to emulsify the nucleus. Please understand, you emulsify the nucleus. You make a small trench there. So in that area. So what happens is you debulk the nucleus and prevents the nucleus, because these nuclei are all very bulky. They'll come forward. So you want to do a small
decompress
trench,
also.
Push the nucleus
and decompress.
And at the same time, you are decompressing the front and the back compartment.
So now we move on to Dr. Balla's video. No more.
Thank you so much.
Yeah, Sunil, please.
Thank you very much, Dr. Anand. Thank you very much. Yes.
Very nice, Anand.
So I got a series of opacified. I think audio is not coming. I got a series of opacified IOL, and suddenly in last we had 4 opacified IOLs, and these were all similar, and they were hydrophilic lenses. And there are various mechanisms which are supposed to be the exact mechanism is not clear. They say it occurs mostly in hydrophilic lenses. If it is in the capsular bag place, then you find only the central part of the optic is opacified. But if it's placed in the ciliary sulcus, the whole lens may be opacified, as was the case in the present one. So the removal was really tough. Although I could free the hydrophilic lens out of the bag, and I was able to bring it into the anterior chamber, but there was all sorts of manipulation being done in spite of using liberal amount of the viscoelastic. You see the iris is prolapsing out, and the lens was cut into 2 pieces, and it is being removed. But you see the amount of trauma which was there was visible. I didn't like that amount of trauma, because although the endothelium was coated very nicely with the dispersive viscoelastic, but still I found that there must have been some damage to the endothelium also. And then I placed the IOL inside and put a suture there. So I got an idea, where is the need to do all this acrobatics and manipulation? If I just use my SICS incision, make a wider incision, then I don't need to do all these manipulation in the back, because the incision will be self-sealed. And the main important part is not to damage the posterior capsule, not to cause undue damage to the endothelium. So I made a small incision, cataract surgery incision. It was about 5.5 to 6 millimeter, and I just using liberal amount of viscoelastic both behind the opacified IOL and in front. I could just slide out the this opacified IOL, and this I found was much less traumatic. So there was this is where you can need SICS expertise to remove it. And then I slid the IOL, the acrylic IOL, of course not hydrophilic this time. I used hydrophobic lens, because they say hydrophilic lens are more prone to this, although the incidence with hydrophobic lens is very, very less. But so I use this technique to just remove the opacified IOL without doing acrobatics, without trying to cut it. And this is how I have started now explanting my opacified IOLs, and using this larger incision of small incision cataract surgery. Here you find that after sliding it inside, I'm just trying to slide it back into the capsular bag. Luckily for me, the capsular bag was not damaged. Otherwise, I would have to use 3-piece IOL in all these cases. This is how I'm just hydrating the side port incision, hydrating the little bit of the corneal lip of the small incision cataracts, sclerocorneal tunnel. And this is what I found. There was much less trauma, and the specular count was also quite good after the surgery if I compared the two techniques of using bigger incision compared to a smaller incision.
Thank you very much, Dr. Valla. That was a different kind of a situation, and how well you handled it. I believe that these kind of opacified IOLs are hardly ever there, because these are hydrophilic materials, and as theory goes, they are seen in eyes which get inflamed. They're seen when silicone oil combination with a hydrophilic lens, you can see them. And also, if the lenses are kept in a very cold temperature, they have to be brought back to room temperature. And apparently that high temperature differential could also be a trigger. But I don't think these are all manufacturing defects largely. And of course, when it comes to removal of the lenses, the only challenge is not just, even if it's a very atraumatic surgery, the amount of astigmatism which is induced is what has to be factored in, and cutting these IOLs is the best way to deal with it. If there is any extra point which has to be added.
May I comment?
Yes.
Yes. We have published 2 such cases in JCRS case reports in 2017. As Bhalla sir, always wonderful to see you and to learn from you. The other thing is what sir has correctly said, we did both through the SICS incision. So it was much better, because, and plus the challenge is it's always done somewhere else. They were hydrophilic lenses. So the integrity of the posterior capsule, or the zonules and all were there. Cutting it while just lifting it slightly with viscoelastic behind it and just cutting the haptics was much easier on both sides to give two cuts to the optic, to remove it and then implant a non-hydrophilic lens, a hydrophobic lens. Thank you.
Anything to add, Mohan? Shall we go on to the next? Yeah.
Chitra, I just have one point. What I do is, when I see an opacified, in fact, we have reported 26 of these lenses way back in 2002. And I named this video as a whitewash. I presented that in the ACRS when David Apple was chairing the session. And it was 26 lenses of the same company. It was called MDR in India and GDR in the US. It's an FDA approved hydrophilic lenses. We explanted all these lenses. But what I do is to make sure that you have good viscoelastic, implant a lens in the back first. Bring the opacified IOL into the anterior chamber, implant a lens, because I don't want to damage the posterior capsule, because the entire battle will be lost. Then cut these lenses. You don't have to cut fully. And then you just require a 3 millimeter incision, and you use what is called the hand-on-hand technique. And especially the hydrophilic lenses come out through very beautifully without any problem.
Wonderful. That's the most important message which was needed. Thank you so much, Mohan.
Yeah,
we shall now go on to our next speaker. Bala, that was very nice. You brought out something which is not commonly shown, and a lot of learning in that small video.
Thank you, ma'am.
We shall now go on to Dr. Bastin, who is the Medical Director of Netra Eye Care Center, Irinjalakuda, which is in Kerala, close to Trichur. And he is also has his consultation at Little Flower Hospital, Angamali, and is also been holding innumerable posts at the Kerala State Ophthalmic Conference and has had many awards and accolades to his credit. And he is going to be showing another very challenging moment in cataract surgery. On to you, Dr. Bastin.
Is my screen visible?
Yes, yes, yes.
Yeah. At the outset, let me thank Dr. Chitra for including in this program. My case presentation is regarding a 72-year-old female who came for cataract surgery. She had no systemic illness and she was not on any medication. Ophthalmic examination showed nucleus sclerosis grade 1 in the right eye and grade 2 in the left eye, and she was posted for left eye phacoemulsification under topical anesthesia. It was just like any other cataract surgery to begin with. The problem started with irrigation and aspiration. This is the video showing the final part of the irrigation and aspiration. And there was increased resistance to pull and separate the cortex. And as you can see here, it was the posterior capsule also was coming along with the cortex when I tried to remove it. And there was prominent folds in the posterior capsule, but there was no PC wrench. And I was suspecting a zonular weakness, but inserting a CTR was out of question because there was literally no space in the back. Finally, I could manage to take all the cortex with a well-centered CCC, but the story was not yet over. When I tried to remove the IA probe, I found that the AC was swallowing. So I tried to form the anterior chamber with viscoelastics, and I injected viscoelastic through the side port and removed the IA probe. As you can see here, when I removed the IA probe, the iris also started coming out along with the probe, and I tried to repose it back, but I couldn't place the IOL because there was no back space in the back. I released the speculum and tried to form the AC, but iris was coming out. This cycle was repeated again and again, and I stopped the surgery in between, explained the patient everything, and shifted the patient to the post-operative care, waited for 1 hour, and brought her back to the OR again. Surprisingly, everything was normal, and I decided to implant the lens. A single piece IOL was injected, and as soon as I injected, the iris started coming again, and AC was very shallow this time also. And I tried to put the haptic into the back, and with great difficulty, I could manage to put one haptic into the back. AC was still shallow, and as you can see, the iris was out of the main wound. And I tried to rotate the IOL, but I couldn't do it. And I managed to get the other haptic also into the back. So both haptics were in the back, but the iris still out of the wound. And I tried to repose it back, but it was not going in. And surprisingly, I could see that one haptic was coming out again from the back. I didn't know why. I made another wound and tried to put it back again into the back. And I could somehow manage to do that, as you can see here. Now, I thought both haptics were in the back, but to my surprise, unfortunately, the other haptic started coming out. So one haptic was in the back and other was in the sulcus. The AC was again shallow, and I didn't know what to do exactly. So I explained the patient once again. We had to stop the surgery. I stopped the surgery in between and took the patient out of the operating room to the post-op care. At this time, I gave injection mannitol 300 ml IV, gave a peridural block, and waited for 2 hours. After 2 hours, again, it was looking all right, but one happy was outside. I managed to keep it inside the bag. I could do the case reasonably well without any complications. And I wanted to present this case to know what went wrong here and what could have been done better. And is it entity called acute intraoperative rock hard eye syndrome? Thank you very much.
Thank you very much, Doctor, for this wonderful video which you showed here. I would feel that this is what is called a fluid misdirection syndrome. Yeah, it could be because there could have been some zonular weakness and there could have been a hydration of vitreous which could have occurred, or it could have been a hypermetropic eye. I'm not sure. Was it a hypermetropic eye?
It was, it was hypermetropic.
Yeah. So these are the eyes wherein this kind of a situation can happen. But if there was no contraindication to using mannitol, I would have stopped it much earlier. You are a very brave surgeon and very daring, and you did what you did. But if there is no contraindication to giving mannitol, you should give mannitol at that time, or close the case, take it up after giving mannitol outside and then bringing back the patient in. Or third, you might have to even abort the case, do an ultrasound to rule out a suprachoroidal hemorrhage, whether it was something like that. So thoughts of the expert panel for all the questions which have been raised.
I think it's a beautiful video, Chitra.
Yes.
It's a clear case of AIOS, acute intraoperative rock hard eye syndrome. Very commonly seen in patients who got pseudo exfoliation. When you have pseudo exfoliation, what happens is the zonules are weak and the fluid goes behind, hydrates the vitreous and pushes the posterior capsule. There's a positive pressure. So what is important is first is to give intraoperative or mannitol, about 50 cc bolus I give, and then we can even put a needle into the pars plana area. Okay, I put a needle and aspirate the fluid from retro lentil area. Okay,
I wouldn't agree, because these are small eyes and we don't know exactly.
No, it's not an anophthalmic eye. This is not an anophthalmic.
Oh, you are a retina surgeon, but I'm not sure whether anybody and everybody can put a needle into the vitreous and remove vitreous at that point. You are definitely, there would be.
No, we're not removing the vitreous. Please understand. We're just putting a 24 gauge needle through the pars plana. We're just removing the fluid. There is a fluid, lot of fluid in the anterior vitreous face, which is actually pushing the posterior capsule. If you push that, do that, or you can even put a trocar and cannula. Okay, you can put a trocar, but you don't have to go inside. Just do a vitrectomy at the edge, at the entry point, and that will take care of the positive vitreous pressure. But before
can I suggest a couple of points?
Yeah, but before you put a trocar and cannula, you examine do an indirect ophthalmoscopy, make sure there's no expulsive choroidal hemorrhage or anything like that. So that's very important.
Okay, can I just a couple of points from my side, observations, Dr. Chitra, Dr. Mohan, Dr. Anthony, lovely video. I feel there is rather than whole zonular weakness, my observations are in a very small percentage of patients, you have more of posterior zonular weakness. So in the last part of the cortex, when you're actually taking the whole back tends to come up. So in this, there were both the factors. One was, of course, the misdirection of the fluid, the irrigation fluid into the vitreous. The second was, I feel, a bit of zonular weakness, which compromised. So you got a zonular weakness with a hydrated vitreous, you were having problems doing that. It's not common, but it's definitely makes life very difficult. But I think in giving mannitol in a hypermetropic eye, I feel broad out anything between 18 to 22, you are at the borderline in terms of having intraoperative pressure. So I would definitely consider giving mannitol whenever you have that in the first instance itself. So I would agree with Dr. Chitra on that point. Maybe an earlier decision to give mannitol would have definitely helped.
Just a 50 cc bolus.
I actually also believe, I don't know what the experts would do, but in a hypermetropic eye, that's the only situation where we give oral glycerol pre-operatively to the patient half an hour before the surgery, before we take it up. and it's a very smooth scenario. Go back and do it if you're not doing it. We shall go on to our next speaker, Dr. Jignesh Parekh. Very nice. Dr. Jignesh Parekh, who is a medical director at Shivam Eye Hospital, Vadodara, Gujarat, and he is going to show us something interesting, maybe can raise some controversy. On to you, Dr. Jignesh.
Thank you, madam. Good evening, everyone. And today I'm showing 2 cases of managing posterior polar cataract. Madam, I'm audible?
Yes, yes.
Okay.
So,
very much.
Yeah, thank you, sir. So this is a case of posterior polar cataract with grade 3 nuclear sclerosis. So doing inside out hydrodelineation, I'm initially doing trenching of the central nucleus, and now I'm doing inside of hydrodelineation. Now I have to emulsify the nucleus, but the only challenge is I can't dial the nucleus as not to give any pressure to the posterior capsule. And so I am trying to crack and emulsify the nucleus as much as I can. Here I'm keeping all my phaco parameters very low. I'm doing as much as I can. Now maintaining the closed chamber technique. I'm injecting visco before removing my phaco probe. I'm rotating, or I'm doing the flipping the posterior or sub-incisional part as to emulsify, and bringing in the AC and in the center. I'm emulsifying it. Here, every time I'm maintaining the entry capsule or anterior chamber, and I'm trying to see that there is no pressure over the posterior capsule at any given moment. Here, the epinuclear plate is very thick, as I have done inside out hydrodelineation. So instead of doing removing with IA probe, I'll be doing with phaco probe only from the periphery. So I'm trying to remove the peripheral parts of the epinuclear plate as much as I can without giving any pressure to the central posterior pole. And same closed chamber technique is maintained every time. Yes, I'm removing as much as I can from the periphery. All right, closed chamber technique maintained before removing phaco probe, injecting phaco visco. And now the main part is to separate the posterior capsule from the epinuclear plate. I am injecting dispersive viscoelastic, and now the things are very easy for me. So I can do easily. This is a second case, bit a challenging one, as patient is told by 2 renowned surgeons that this is a clear-cut phaco posterior polar cataract. So same, but here the nucleus is very soft. So instead of emulsifying, I will just aspirate the nuclear part with phaco probe. But here also I will not rotate anytime, not to give any pressure to the posterior pole or posterior capsule. Same way, the epinuclear plate is very thick, so trying to remove by my phaco probe only as much as I can from the periphery without damaging the center part. Closed chamber technique is maintained. And now to separate epinucleus from the posterior pole, posterior capsule, I'm again trying to remove the epinuclear plate from the other sides. Still,
what happened?
What happened? Anyway, I think he has shown quite well. He has tried to show inside out hydrodelineation and going forward. Now, I have just one question here. If we already know, we have done an ASOCT, and you know that there is a PCR in this particular case, besides the option of doing a femtocataract platform doing, which would ease up the manipulations in these eyes. If you were to do a straight phaco and you know there's an open capsule, what would be the extra things you would do? Dr. Mohan, Dr. Malay, any one of you could tell me?
Okay, if you know that there's a pre-existing
yes. Yes.
dehiscence of the posterior capsule.
Yes.
Okay, if you don't have access, of course, I do femto, but
yes.
if you don't have access to femto,
yes.
what I would do is the same parameters. I would prefer to use a Centurion machine. The simple reason I have better intraoperative control with active fluidics and IOP control, everything is much better. If you don't have access to a Centurion machine, it doesn't make a difference at all. So what is important is to lower down your parameters and now and then inject, make sure that you inject a good viscoelastic like Viscoat and come out of the eye and keep the parameters low. Do not try to rotate the nucleus and make sure that when you remove the last piece, that is the epinucleus, you make sure that you put a Viscoat underneath that, and then you probably, if there is a pre-existing, obviously there's going to be vitreous there, and put tricot and then go ahead. Usually this dehiscence, the pre-existing dehiscence which is there, it is not like a typical posterior capsule rupture. It is like a two pillars on the posterior capsule. It will be two parallel lines.
Yes.
So
yes.
that's what I think is very important for you to, you can actually, if you see that, if you have IOL master 700, you can actually see it preoperatively. You can see those delineation on the posterior pole of the lens very clearly. And the parameters are very important. Only thing is you should have a plan A, plan B, and plan C as far as IOL implantation is concerned. Tell the counseling of the patient is very important preoperatively also, and don't go for, don't promise them any premium lenses. I would prefer that if it's a two pillars, go for a multi-piece lens in the sulcus and capture the optic into the rexis margin. So, yeah.
Anything else? Anybody has any point to add? Most importantly, don't allow the anterior chamber to shallow and ensure that the hydrostatic pressure in the bag remains the same. There is no fluctuation on the bag, and that would may not prevent the epinucleus or any of the cortex to be dropping into vitreous, but you could salvage most of it, and you might get away with just a clean PC tear, and you can do an anterior vitrectomy. Dr. Malay, you are not there. Dr. Manisha, anything to add here before we go on to our last speaker?
No, ma'am, it has been a wonderful set. I just want to give feedback from all my PGs and all they're watching. It's wonderful. Thank you so much, ma'am. It has been really amazing. Thank you.
So we shall now go on to our last speaker, Dr. Ankit Agarwal, who is again is a phaco refractive surgeon and has immense awards and credits to his name. And he is going to be showing us again a case of an intumescent cataract and how he managed it, a little different. And there is a learning tip there for us before we close for the day.
Am I audible, ma'am?
Yes, yes.
Hi, Ankit.
First of all, hello, sir. Good evening.
Hello.
First of all, I would like to thank Chitra ma'am and AIOS ARC for giving a young surgeon like me an opportunity to present.
By the way, he's from Prayagraj. Yes, I should have said that in the beginning. I actually started telling something else. Tell me.
So the topic is intumescent rexis made easy. My technique which I use is the double rexis method, in which first I do a small rexis in the center and then I extend, as discussed already during Dr. R.K. Sharma's case by Chitra ma'am. Now, during the COVID season for 1 or 2 years approximately, patients were very afraid to come to the hospitals. And post-COVID, there was a glut of patients with hypermature and intumescent cataracts. Now, this was the case which we operated, and as soon as I put a nick in the AC, suddenly this happened. Now, for a young surgeon like me, it was a very challenging thing. So soon I realized that I need to make a rexis perfect because I'm not a VR surgeon. I cannot handle a nucleus drop myself. So first, in the AC, I put a very high viscosity viscoelastic. The one I prefer is a 3% sodium hyaluronate. Now, by making a small rexis and using IA to debulk the nucleus, then I can increase the rexis using a microhexis forceps. This gives me optimum control, and a rexis of approximately 5.5 to 6 mm can be achieved without any problems. This is another case in which, similar case in which I have done this. 3% sodium hyaluronate solution is used in the AC, and a small rexis is made in the beginning using first technique is made in system. A Kelvin needle made as already discussed before, and a small rexis using micro rexis forceps. Then using IA, some amount of debulking is done so that the interlenticular pressure is less. This will reduce the incidence of radial tearing. Then again, the AC is filled with high viscosity viscoelastic, and the rexis can be extended. This is the third case, a similar case, but in this, the cortex is not at all milky and there is no fluid egress. This kind of hypermature cataracts are very dangerous because since the cortex is not milky, automatic debulking of the nucleus is not present. And this kind of cataracts can result in a lot of rexis runout cases. Similarly, debulking is done. You can see that debulking can be seen using IA. What I do is I press the nucleus a little bit and rotate it in the bag. This will reduce the cortical matter behind the nucleus also, and thus it is completely pressed to the posterior capsule. Now rexis is extended using micro rexis forceps. Now, in spite of all these efforts, sometimes the case may run out. And in this case, due to not having micro rexis forceps, I was using Haldi Poker's rexis forceps. Trying to make a small rexis in the beginning, but as you can see, because I don't have a micro rexis forceps, some amount of viscoelastic is leaking out from the port, and this resulted in the rexis kept running out, and I was not able to salvage it in the beginning. To reduce the interventricular pressure on this side, I make a small cut on the opposite side. Thus, it will prevent running out of the rexis from the side of the runout. Now, I have to make the rexis as round as possible. So a small nick here and making it round. By this time, my assistant brought me the micro rexis forceps. And I could now make something similar to like a rexis, but with two runouts. In this case, I have to bring the nucleus in the AC and complete the case, just like Dr. R.K. Sharma.
Dr. Ankit, that was a truly wonderful video which you showed. The consistent, really needs a clap. Consistent, nice round rexis and doing multi-quadrant IA so that you're totally debulking the soft cortex out and then going on to extending your rexis to a beautiful, each video after the other was a teaching video. And the last thing which you showed was also an excellent learning tip, is the making an extra nick, because that would prevent the wraparound rexis tear happening, and how you converted into what near normal round and completed it. I do not have any questions. I just wanted to extol what you did so well. Mohan Rajan, Dr. Malay, Dr.
Ankit, I think Chitra, you reserved the best for the last.
Yeah.
Ankit, beautiful videos.
Yes.
What is important is, I think you have done the small rexis, but after the small rexis, this is what I'm trying to tell everybody, that please understand that when you do an irrigation aspiration, it is not only the front compartment, but also the back compartment. The back compartment also has to be decompressed. The back compartment that's why you are rotating the nucleus, and the fluid from behind the nucleus is also coming off. Okay, so that also prevents the Argentina flag sign. Wonderfully done, lovely videos. Really, kudos to you.
Yeah.
Thank you, sir. Thank you so
In
much.
fact, I think it has been any other comment from anybody else before we conclude? I think we all need to.
I want to make one comment, Chitra.
Yes.
Friends, I hope all of you will agree that you cannot have a more energetic chairman ARC than what Dr. Chitra is.
Clap, clap, sir.
Yeah. We should all give a standing ovation for her.
Yes, yes.
The simple reason is, you can do 1 or 2 webinars, 5 or 10 webinars, but doing continuously on a sustained basis, and each and every webinar is successfully hitting the top is something which is really, I know how much of hard work and effort she has taken. So seriously, hats off to you, Chitra.
Yes,
I'm truly amazed by your energy levels, your dedication, your enthusiasm, and your commitment to ophthalmology and teaching, which is again very, very important for all of us. Your passion for everything. Hats off to you.
All the ARC members are seconding you.
Yes, yes, true.
Thank you so much. I'm so overwhelmed. I always know that Mohan and my ARC people have a very special thing, which probably that is what pushes me forward to do what I do. But I truly have loved this post, and I have just no words to tell you how much I have loved every moment which I've worked with you all. But more importantly, going further, I hats off to my so self-confident, who never let a lacuna appear at any point of time, and the distant one actually included to be discussed in this wonderful video. I need
line is going off.
Yeah, that's true.
Chitra.
Only, yeah. Yeah. Can you hear me?
Yeah, now you can
Can
hear.
you hear me now?
Yes.
Yeah, so that was so wonderful. The kind of speakers and the kind of videos you all had to show, all very self-confident surgeons. You all really made this webinar a moment, a Friday, a day to remember. And I need to especially thank my ARC team. Believe me, you all need to know, to work with them to understand the kind of dynamism and brilliance they have. If I step aside, all of them can do all of this as wonderfully as you believe that I was trying to do. Very special thanks to Mr. Kripal and the AIOS team for being our background support in helping us. It goes without saying that Mr. Sunil is just a very special human being who has constantly, sit through these webinars and is constantly just a word away. Mr. Sunil, I have to say, and is somewhere back there to help us. So I think we need to thank him for the smooth running of the webinar. Our thanks are due to Mr. Sai and Manjula from Numotech for all the mails which come to your inbox. And finally, I need to thank my little young office staff, Mr. Velmurugan, who's always there in the background. And most importantly, our thanks are to Entode, the video which you saw. They have been a constant support. I have never had to talk to them. I have never had to meet them personally, but they are constantly there behind us to ensure our ARC webinars are well sponsored. And finally, thank you all delegates. I'm sure you would have enjoyed it, and some of you would watch it later on. Thank you one and all. Thank you very, very much.
Thank you, ma'am. Thank you. Thank you.
Thank you, madam.
Thank you.
Thank you. Your videos are wonderful, Dr. Subhash. Truly wonderful.
Chitra, are you providing the